invite for this exciting webinar, which is focused as Precision Oncology Unplugged. And it's a great pleasure to welcome and invite our program convener, Dr. Sandeep Jasuja, Medical Superintendent at the State Cancer Institute, Head of the Department of Oncology at the prestigious SMS Medical College and Hospital, Jaipur. Without wasting any time, may I request Dr. Sandeep sir for his kind words of introduction, and then we will invite the chairperson. Sir, over to you, please.
So very good evening, my dear esteemed colleagues, guests, and friends. It gives me an immense pleasure to welcome you all to the Precision Oncology Unplugged being held on the 21st and 22nd May 2025 under the academic leadership of our team, State Cancer Institute, SMS Medical College and Hospital, Jaipur. So as we stand on the frontier of the transformative advances in the cancer care, this conference is designed as a platform to unlock the latest breakthrough in the molecular oncology, targeted therapy, immunotherapy, and precision diagnostics. With the exceptional lineup of the national leaders in oncology across the multiple specialty, from the lung, breast, DU, GI, and hematology malignancies, we are all set to engage through provocating discussions, insightful panel deliberations, and cutting-edge data presentations. The presence of all of you, renowned clinicians, researchers, academicians, and future leaders, amplify the value of this our gathering. Your experience, curiosity, and commitment are all what will make this forum like this catalyze to progress in the oncology field. So let's this be a more than just an academic interaction. Let it be a celebration of collaboration, innovation, and the shared vision for a cancer-free tomorrow. So on the behalf of organizing team and committee, I wish you all 2 days of the rich learning and inspiring engagement, and especially thanks to our panelists, chairperson and team Tarun, and all of you, I welcome again all of you in this academic phase. Over to our chairpersons and
Yeah, so thank you so much, Dr. Joseph, for this kind words. And now it's a pleasure to welcome and invite our chairpersons, respected Dr. Dilip Ramnakhari sir. So thank you so much for joining. Sir is a senior professor oncopathology and the chief of GI hepatic and pancreatic biliary pathology, SMS Medical College and attached group of Hospital, Jaipur. Good evening, sir, to you. We have
Good evening,
Dr. JB
Tarun. Good evening, Tarun, and thanks to Dr. Sandeep Jasuja for inviting me.
And we have to co-chair Dr. JB Sharma, sir, Director of Medical Oncology at Action Cancer Hospital, New Delhi. And we also have Dr. Pawan Agarwal, sir, Senior Consultant Medical Oncologist at the prestigious Bhagwan Mahavir Cancer Hospital and Research Center. So the agenda is before you, and we request all of you to please start the session. Dr. Dilip, sir, if you can just invite our moderator for the session. Over to you, sir. Hello, Dilip sir. Can I invite the moderator, sir? So without wasting time, hello.
Please go ahead, Tarunji, and invite the moderator.
Yeah. So we have a pleasure to welcome and invite the esteemed moderator for the session, which is on panel discussion NGS ctDNA liquid biopsies. And it's a pleasure to invite Professor Akhil Kapoor, sir. Good evening to you, sir, and welcome from Tata Memorial Hospital, Varanasi. Now the floor is set. You have all your esteemed panelists with you. So Dr. Akhil, sir, over to you, please.
Yeah, thank you to the entire team. Thank you, Dr. Sandeep, for inviting me for this very innovative theme and a very directed theme of precision oncology, because precision oncology is the way to go. And it seems that all of our colleagues are now striving towards that. So it is very heartening to see that. So I invite all the panelists, Dr. Vikas Asati, Dr. Santosh, Dr. Sunil Pasricha, sir, Dr. Amit Verma, Dr. Krupa Shankar, Dr. Vikas Talreja, Dr. Tarachand, and Dr. Ekatwala. So if all are available, I can start. I had also requested the team to share my slides. So in the meantime, the slides are being shared. I will request my colleague, Dr. Vikas sir, Dr. Vikas Talreja.
Very good afternoon.
Good evening, boss. Yes. Now we're the field of precision oncology. First of your thought and comments when you hear the word precision oncology. What is your message to all your juniors and colleagues? Yes, sir.
So all of us have identified that over past many years, oncology is a heterogeneous disease, and we need to pick up the right mutation for the right cancer, and to identify them and also to target them. And we have seen all across, be it NMSI, NTRK, HER2 new, L, cross, every cancer has certain type of target where we need to find out as what is driving that cancer. And if we hit at the right time the target, the better it is. So probably it is evolution, and precision oncology so far has changed not only way we manage the metastatic situation, but also in the adjuvant. Many of our colorectal cancers also are based on more and more circulating tumor DNA detections. Our therapies are getting modified based on the MRDs and the tumor DNA detections for many of these. So that has changed the traditional way of treating cancers from clinical, radiological to more of right now genomic assessments also.
Yeah. So thank you, sir. Thank you for your important comments to start this discussion. Now we'll directly go to Dr. Amit Verma. Are you available for comment, Dr. Amit?
Yes, I'm available.
Yes, Dr. Amit. You have been a very dear colleague and guide to us, and you have helped a lot of medical oncologists to get to do shared decision making and select the best possible treatment for our patients. Now, when you see the various tests which are available in various labs, there's n kind of tests which are available in terms of NGS also, ctDNA also. So I will request you to give some very brief and important points which the medical oncologist should look at before deciding which lab to choose while sending either NGS or ctDNA like tests. Your comments on the same.
Thank you very much, Akhil, for asking this very pertinent question. And this is the advancement of technology have led to develop this particular test called liquid biopsy or ctDNA testing. And various labs, as you rightly mentioned, are offering these particular tests. So the important key points which I would emphasize on is the number of genes what people are analyzing makes a lot of sense. Second, the kind of alterations what they pick up, especially the fusions. Are they able to pick up the fusions and copy number variations? So practically, please pay emphasis on identifying these alterations and the sensitivity of each liquid biopsy offered by them. What is their sensitivity to pick up these alterations? The third category is, are they giving you information on the tumor fraction? This is also very important. And the fourth is the variant allele frequency. Are they offering you all these things or not? And the fifth important thing, liquid biopsy carries a lot of signatures for the germline alterations. Are they identifying the potential germinal alterations or not? The sixth would be if the liquid biopsy are they commenting on whether this is the somatic mutation versus the chip mutation. So if the laboratory is doing that due diligence for you, so that information is sufficient for you to take a appropriate call for your patient, and that is what I'm particularly looking for. Further to it, if you can look for actions, the CAP and the NABL to make sure the quality is paramount, and the validation, internal validation if they have already done. And that should be enough for a clinician to take a call which lab to send their samples and how to really interpret the reports based on their panels of liquid biopsy.
Yeah.
Over to you.
Thank you. Thank you, Dr. Amit, for highlighting the most of the pertinent points, which all of us have heard, but sometimes unless we discuss in molecular tumor boards, we do not understand about the same. So since we conduct molecular tumor board of TMH routinely, today morning also I conducted the same. I have got these points, informations embedded from the last 5 years that these points are actually very important. But sometimes in the routine practice, it might be missed. Thank you for highlighting for the benefit of our colleagues and juniors. Also, one more pertinent point which I would like to again ask you, Dr. Amit, is how the labs differentiate a ctDNA test, whether it is coming from the germline portion versus somatic portion. So how it is being decided in the lab that it is likely to be a chip versus actually a somatic mutation, how it is decided?
So it's a very important question. So the variant allele frequency a lot whether this is a germline versus is one. So let us assume for a minute that the patient have a tumor burden which is quite low, but the VAF of a particular gene, let us say T53, is more than 70%. So probably we are talking about a germline T53 rather than a somatic P53 in this particular case. On the other hand, if the tumor fraction or the tumor burden is very high, then it will become very difficult for any lab to identify whether it is germline or somatic just by seeing a single test, liquid biopsy for that matter. Regarding the chip mutations, we know there are a couple of chip genes which we are very much familiar, like DNMT3A, AXL, TET mutations. So if you find alterations in these mutations with a very low VAF, you can assume that it's a chip mutation rather than a somatic alteration. But if the VAF goes of these particular genes very high, it have other implications, especially if the patient is treated by chemotherapy or the patient is of old age scenario, where the VAF of these chip genes can be on a higher scale actually. So there are various parameters to look into before labeling them. What exactly are these alterations?
So I
Over
think,
to you.
yeah. So thank you, Dr. Amit, again for highlighting this. These are very, very relevant points and many times missed by the oncologist because sometimes they are not able to get proper guidance from the lab or the molecular team. And that is why we always try to discuss most of our reports of NGS. Now we have done more than 1,000 NGS at our center in last just 6 months. And we have a project of whole genomic sequencing also running at our center. So that all these points actually help us to analyze the report and make whether the report is actually relevant for action. So all these are very, very relevant. So requesting to move to the next slide. I will request Dr. Santosh to consider and I would like to get his comments. So, Dr. Santosh, I think now when we see a patient of lung cancer, we always try to get at NGS and PDL1 done. So, how to select the NGS panel? That is how you select. Apart from the cost, I think cost is very, very important issue. I agree. But if you have a limited amount of fund, for example, 30,000 or 40,000, what type of panel you would like to select in your practice, Dr. Santosh?
So, sir, first of all, basically, whenever we approach treating a patient, it's always important to know the wholesome information about the disease of 360 degrees, whether we have an actionable thing or not. There are a lot of co-mutations and background noise that ultimately influence the treatment choices. So, what is the test that to be recommended is always the tests that are run in the large scale phase 3 trials that have tests that are proprietary tests. So the test I do on day-to-day basis are not equivalent to what I want to done, because I work in a private center. There are a lot of logistic issues, but how do I choose this? I ask the individual lab, what is your data of comparison with the proprietary test? Suppose we say Garden 360 or Foundation one. Have a comparison analysis, and what is your population database that you are updating? So sometimes today's VUF might be futures pathogenic. So how are they updating and how are they pulling the data, and how is the computational algorithm of the data? So, and are they doing synoptic reporting and all? I ask the lab head directly. I phone him. So suppose a mutation comes, I ask him what is this thing and what is the VAF and all. Sometimes they do not mention VAF. There is no synaptic reporting. I frequently discuss with them, ask them, I want the reporting in a proper synaptic manner, mentioning they sometimes carefully omit some points in their favor. So I would revise the report and ask them to release. This is how I select the lab. Sometimes the lab I would be unhappy with, I will change the lab. So there is no perfect lab. It's always a interaction with their scientific team, their bioinformatics and scientific team. then I would grasp more information so that my patient will get benefit. Suppose previously we used to do only EGFR, but we need to know the TP53 also now, how it influences the thing. The more is the better as of now.
Yeah. Thank you. Thank you, Dr. Santosh, for highlighting those very relevant points. And I was just highlighting on the screen some of the very important things which are there. First, when we order the test NGS, we wait. The report kab aayegi, kab aayegi. Patient keeps on asking report kab aayegi. Then when we get the NGS report, sometimes what happens, we feel, oh, ये क्या हो गया, ये क्या report आ गई, अब क्या किया जाए? So all these are very pertinent and real world problems. That is why, again, there is a very important role of molecular oncologist in our settings. And we try to discuss the reports as much as possible with the molecular oncologist or at least molecular pathologist who is available in-house. Or even if not in-house, we try to do molecular tumor boards. Now, thankfully, there are some national tumor boards running in our country, which help us and various other centers who do not have molecular oncologist or molecular pathologist to understand the report more deeply and whether to act on the report or not to act. So that is most important. Acting is easier. Not acting on a report is more difficult. So that is a very, very relevant point. So Dr. Vikas Asati, I will request you to comment. When you see reports, for example, a patient with ALK fusion report, and you are seeing some co-mutations. So do that reports co-mutations help you in taking decision regarding the first line LTKI?
So I think it is important what other mutation apart from the the main driver mutation the patient is harboring. As Dr. Santos also suggested, the concomitant P53 mutation. And as far as you ask for the lung, sometime when the variant, variant type 1, 2, 3, that is also important. So if there is a co-mutation, we can use a better, more effective TKI. So I think not only the driver mutation, the other co-mutation are, I will say, equally important than the driver mutation. It is like important.
Yes, yes, completely agree. So yes, we take P53, PIK3CA, P10,
Yes.
and CDKN2 mutations very, very seriously in lung cancer, though they might not be actionable, but they help us in taking decision regarding either the EGFR TKI or LTKI both. In, for example, if we take example of EGFR TKI, we now have data of both OC plus chemo and amivantamab plus
Yes.
TKI, so they'll help us to decide. At the same time, ALK fusion, type of fusion, the concomitant mutations help us to decide whether it is fine enough to go ahead with drugs like alectinib versus lorlatinib. Sometimes they help us. So yes, as highlighted by Dr. Vikas, it's very, very relevant to look at the entire report, just not read the first two lines of the report, ALK fusion positive, and you forget about the rest of the report. So we have passed that time when only getting information whether ALK is positive or negative. Now it is not ALK positive or negative. We have to know ALK fusion type 1, type 2 versus type 3, which are the co-mutations, if any, and if co-mutations there are, which co-mutations, and whether the report is baseline report, what is the copy number. All these points are very, very important. What is the read count? So all these points are very, very important. And when writing the report and diagnosis of the patient, we try to write the entire all these points, then the diagnosis becomes complete. So ALK positive lung cancer is not enough now because we are living in a precision oncology world, as Dr. Sandeep D'Souza also highlighted at the beginning, and we need to precise it, and it starts from our clinic, and we need to take care of the same. Now, moving further ahead, we have, I think, from the lab, Dr. Sunil Pasricha, sir. Dr. Sunil, if you are available, I will take your. Yes, sir. Yes, sir. Sir, so now in lung, always tissue is the issue. That is the most common word which I learned from our pathologist, Dr. Rajiv sir at TMH Mumbai, and now we keep on hearing about the same still now. So sample not sufficient. So sometimes what happens when we send for NGS, after 5 to 7 days, we get a call from the lab, the sample is not sufficient. So what is your guide to the clinicians to make sure, and what is your guide to the other pathologists, because some might not have oncopathology experience. So what we should disseminate in the general community so that their sample is adequate for at least NGS and PDL1 for lung cancer, sir?
Yeah, so Dr. Akhil, so at our institute, the tissue is actually not an issue at our institute. The reason being that if the biopsy is done in a good way, so and you have, suppose you have 6 to 7 or 8 or 6 to 8 cores, if they are taken out, so they are good enough. The thing is, the message is more to the pathologist that you should not embed all the cores in a single block, because whenever the block is cut, all the 8 cores will be depleted at one go. So we have to embed the cores in the 2 or 3 different blocks, and when the slides comes to us, the HND slides the very next day. So what I do is that I prioritize the section. Suppose I have a section which is having a highest amount of the tumor fraction, so I will label on the slide. I write with this marker I am having on my table. So I write over the slide that this is for the molecular, and I write the tumor fraction as well, 80%. So I will not touch that block. The second best tumor fraction, the slide which is having that, I will utilize for the immunohistochemistry. Like I'll straight away go for a limited panel as recommended by the WHO, go for TTF1, P40, and ALK and PDL1. So these 4 markers I give straight away and I report on the very next day. These ALK, PDL1, and P40, TTF1. So we should not go for many other markers and just to satisfy, like you may have some other differentials also, and one should consult with the medical oncologist that the primary etiology is likely to be in the lung only. So we should not rule out the metastatic unnecessarily, because the PET scan findings are very much informative, that you have a mass in the lung and you have the regional lymphadenopathy and bony lesions and all that.
Yeah, so these are very important messages which we should, as a medical oncologist and as our pathology colleagues, and also our intervention radiologist or radiologist who are taking the biopsy. So this is a very important message for lung. Like in prostate, the standard of care is at least 12 core biopsy. Similarly, for lung, now the standard of care is 6 to 8 core biopsy minimum. So that is what we try to do, and at all oncology centers now it is being considered. But sometimes getting an outside block is always a problem. So again, sir, any suggestions what should be done for an outside block? Because patients are sometimes reluctant to do a repeat biopsy. What is your suggestion for both pathologist and oncologist?
So I think if the diagnosis is suppose if it is an outside block and it has been reported by a good lab like NABL accredited lab, so just I think there is no point of repeating the immunohistochemistry markers again, because that will lead to depletion of the tissue. Just a morphological guide that it's an adenocarcinoma is there, we can proceed for the NGS, provided the tumor fraction is at least 10 to 15%. It is there.
Okay.
That can be subjected to NGS.
Completely agree, sir. So yes, we need to save the tissue, and I see might not be required to be repeated unless you have doubt about it, or the lab doesn't have good credibility. So completely agree with you, sir. Thank you, sir, for these very important and pertinent comments. These are sometimes most of us will know this, but we are not able to either express it or collate it in this beautiful format which you have already highlighted. Thank you, sir. So now moving ahead, in lung, there is always a difficulty in discussing whether you have to do tissue-based only or ctDNA-based NGS or both together. So when tissue is the issue, yes, ctDNA-based testing is performed. That is called liquid biopsy is performed. But whether you can go ahead with tissue or liquid both if funds are not an issue. And what is the added advantage of doing double testing? So that is what I wanted to hear. If I can have a comment, Dr. Krupashankar is there?
So he is joining shortly.
Okay. So in the meantime, we'll ask again, Dr. Tarchan is also there or not? Not yet. And Dr. Ektawala?
So all of them will be joining shortly.
Great,
so
sir.
you have currently Dr. Vikas with you, Dr.
Fine.
Santosh. Yeah,
I will. So I will again request Dr. Vikas Talreja for giving his comments. Selection of the two. Sir, how do you select both together if funds is not an issue? And what is your expectation of doing additional double testing at the baseline?
So it is always best to safeguard medico and legally also at the end of the day, because when we each of them doesn't have 100% I would say detection sensitivity. So it's always in the current generation is the FOMO that is happening in all of the generations. So we have the fear of missing out, and that's where I believe we have various roadblocks across the country. So at your center, it might be 6 or 7 at least good cores are being collected, but at other centers, it's not the same. Somewhere 1 or 2 cores are there, and that also gets depleted by the end of the day by the IHC and the other testing being done. So many times the tissue that comes out after 3 weeks or 4 weeks doesn't have that quantity DNA, but because of the reporting, people are being reporting even if the 5%, 7% tumor DNA. So to reply on that insufficient quantity, I believe we need a concordance, and that's why both of them needs to be done simultaneously. Also, the advantage of liquid biopsy is that you have get a report much quicker. You can act upon it. You can possibly see by the time the tissue biopsy report are there that your treatment is working. Is there a concordance between them? Also, with liquid biopsy, you have that advantage of monitoring whatever was your variant allele frequency at the baseline at the end of the treatment scans. So also to corroborate whether it's a clinical, radiological, serological, and genomic response. So I think if finances are not a problem, and even if they are, I believe these two basic tests are going to be like a CBC, LFT, KFT in future, because it is something which is preliminary, where you don't ask patient whether you are affordable for CBC, LFT, KFT. You don't ask patients whether you are afforded for tissue and liquid biopsy, because entire of your treatment is based on this test. If you hit upon the right target, the patient's life is saved. If you miss on those targets, whatever the treatment you give at the end of the day won't be able to make much difference till the time you hit on the right target.
Completely agree. So a very point which is very important, that we are moving towards an era where doing both at the same time will be very, very important. And I can see Dr. Sunil sir also completely agree with the same. And both are complementary, not competitive. There might be some advantage of doing both together. Sometimes when tissue is adequate, even then, sometimes we might be able to follow up the report. For example, in EGFR, now we have some data that we can follow up the report and how is it is doing. New resistant mutations which are appearing, whether that is also changing the treatment paradigm or not, that will also help. So in lung and colorectal, I think there is no good amount of data already for ctDNA based testing is already there. So that, as being highlighted by our very esteemed panel, it is clear. Yes, it is important, and now we are moving towards it. And yes, we know targeted therapies and selecting proper immunotherapy will completely change the way the patient responds to the treatment. And yes, an important point is that now we have so many immunotherapy trials at our center. For example, we have 4 trials of immunotherapy in first-line lung cancer. We select which patient to go into one of the 4 because all 4 are trials in similar setting. But yes, we have so many patients and so many NGS reports the patients are getting. So we, despite having cost constraints, we are able to get NGS testing. At the same time, we are able to give the patient the best possible treatment. I think Dr. Suneet wanted to has raised his point. Yes, Dr. Suneet.
Yeah, hello, Dr. Akhil. Sorry to pitch in between. I think my talk is next. Just wanted to add one more thing. I think we have something known as fragmentomics coming up with us. So what they basically study is the fragments which are already there upfront and which basically are left after giving your treatment therapy. So probably they will be the thing of the future when you are considering this kind of an NGS testing, as you yourself put that EGFR can definitely be followed up. So fragmentomics is something which they are right now studying. It is in approval and definitely will be the thing of the future, as Dr. Vikas also told, that in the time to come, it will be like a CBC or an RFT, which we are doing. Probably if we have fragmentomics with us, we have real-time biochemical assessment of the tumor, what it is and how it is responding. So just thought I'll just add it to that. I mean, please don't mind that part. I thought I'll just add it to it.
Completely agree. Fragmentomics and metabolomics. So these
Yes,
two
yes,
are
sir.
very relevant. And thankfully, our hospital has now a metabolomic lab separately, which has been recently built up. And at TMH Varanasi, we are doing multiple studies with metabolomics. And our focus is presently microbiome testing in lung cancer. And our first DM student has done thesis on microbiome, and that study has just been completed, and it will be submitted to one of the conferences of ISMO very shortly. So we thought that start with directly with microbiome and nothing less before we start at with the first DM resident at our center. So that is how the pace of oncology is that, and we need to understand. And we saw there are multiple discussions about microbiome that is also happening. So my next question would be one of to my again, Dr. Amit Verma, sir, are you there for an important comment about microbiome?
Yes, please, I'm listening. Yes.
Yes. Sir, we had discussed with you about 1.5 years back about microbiome, and we did shotgun metagenomic sequencing for patients. Now, yes, what are the things which you will consider when you are considering the patient has been tested with NGS? There's no targetable mutation. Now the patient is being planned for immunotherapy. So I think this is the area where the role of microbiome pitches in, because we have already some data from multiple cancers, including RCC, that microbiome plays a very, very important role in immunotherapy outcomes. In RCC, there is a data when the patient was given Nivo plus EP as a first line in RCC, the response rates were to the tune of 30%. And when the patient was supplemented with a special microbiome tablet, that response rate increased from 40% to 72%. Though that was very initial study, but yes, that is very important. And that is how I think the things will change in very shortly in the upcoming years. Your comments on the same, sir.
So, gut microbiome plays a very important role in terms of response to the immunotherapy in cancer treatment, which we all are familiar with. So, there are a lot of immune system modulation which happens because of the gut microbiome. And what we know that there are certain gut bacteria which can enhance the antigen presentation and also promote T cell activation and improve tumor immune surveillance. So you can imagine that there is an enhanced immune responses where the immune checkpoint inhibitor work in synergism to show better responses. Um, so these are the basic principles, but still the right bacteria is yet to be identified, which will be given in a tablet form or a kind of a multi-bacteria tablets, which has to be established for each cancer. So there may be a possibility that certain bacteria are showing association with response to particular cancer, but not all cancers. So this is my personal opinion. And top of it, I personally see that that the gut microbiome is a kind of a thing which is modifiable while you go with the treatment. But there are various signatures which can talk about whether it is an immunosuppressive environment or immune activated environment before you initiate immune checkpoint inhibitors, which can also let you know that this patient may need some microbiome modifications also. So I think these are things which I have in my mind, and
so any specific microbiome signatures, sir, which are very important? Do you think
so
find the time?
interferon gamma signatures, which talks about the activated immune system. If you just check the interferon levels prior to immune checkpoint inhibitors and post therapies, you will see that kind of surge, and it is easily doable in the blood. So, but yet in the development phase, not established as a clinical science, but these are the signatures which can identify that the patient will generate immune responses in general. So that is my take on that.
Yeah, completely agree. So we are moving from a phase where we were just discussing about NGS, whether to do NGS or not. In 2 to 3 years back, we were discussing that. In next few days, few months actually, we came to whether to do broad panel NGS versus short panel NGS. Now we are discussing, yes, we know we need to do broad panel NGS and what additional to be done. We have come to that part in so less time. So the last 2 to 3 years have been a frame shift in the way the oncologists think and counsel the patient. So that is why I think the precision oncology, the theme of this conference, is so apt for us and so important in the present era that helps us to decide the treatment paradigm. So I think we tried to highlight the most of the relevant points and the points relevant from the part of the lab, from the point of view of histology, histopathology, from the point of view of a molecular oncologist. So all these points taken together completely state the way that yes, we are in a way where we should act on it and we should be aware of the most important. Dr. Santosh wanted to make a comment. Please go ahead.
Yes. So fantastic moderation. What I feel is the field is evolving to tumor therapeutic vaccines. So that would change the way how we give immunotherapy and all. Already it has proven its role in melanoma and all. Once it develops, that is the right thing. And the microbiome change of increasing the diversity to have more response to immunotherapy. It's where the research is going on. I think in next 3 to 4 years, we'll have a good clinical trials so that further we can incorporate in our real world practice also.
Completely agree with you, Dr. Santosh. So these are the most relevant points where the field is evolving and rapidly growing. In the last 3 years, we have seen so many changes. Next 3 years will be more exciting. And thankfully, we are medical oncologists or the oncologists and of this era. And Dr. Amit, yes, you are.
So
You
I have another important aspect which we are missing while we are discussing the precision oncology aspect of it. As we are doing a lot of genomic analysis, we have an obligation to identify whether this have some cancer predisposition or not, because you have obligation for the family members as well. So while you are focusing on your actionable targets, please try to also focus on the germline possibilities and try to see if you can do some kind of interventions to the patient for secondary cancers and for the family members for primary prevention.
Yeah. So I completely agree with you. That is why we set up a genetic clinic at our center, and now we have done 800 plus genetic tests. And first data is under publication, and our genetic clinic has been one of the most busy clinic in our medical oncology part. So yes, genetic clinics are important. Pre-test, post-test counseling are important. In lung, yes, we have got some specific mutations which are common in our country. T7NTM mutation at the baseline. Always think whether it can be genetic or not. Young patient with lung cancer below 30 years. Yes, we are seeing that 22-year patient with lung cancer. Just I saw in today's OPD. So we have done germline testing in that patient. And there is a important, that is why it is very important to know whether the result is germline versus somatic. And that helps decision making in terms of the family as well. Thank you, Dr. Amit, for highlighting this again very relevant point. So I think this we are living in a very exciting era, and we need to understand a lot more things than just prescribing chemotherapy, immunotherapy, or targeted therapy. We need to see the reports. We need to interpret the reports. We need to see whether the report has been written correctly or not, whether the report is adequate or not. Then if the things are not enough, definitely always discuss with the lab or your molecular pathologist or your molecular oncologist, whoever is the part of your team. And then you can go ahead with that. Thank you, everyone, for the very excellent discussion and very thoughtful provocation. And I thank to all my colleagues and seniors.
So thank you so much, sir. And now may I request Dr. J.B. Sharma, sir, for some expert comments, some thought process from your side. And then maybe Dr. Pawan can invite the next speaker. Dr. J.B. sir, over to you. Your
Yes,
thoughts,
yes.
sir.
Yes. Arunji, thank you very much. First of all, I thank you, Dr. Jasuja, for inviting and hosting this very important conference for precision oncology. And I also thank Dr. Akhil Kapoor, who has conducted that, moderated that very good session. And that role of precision oncology and the selection of the lab and the test and understanding the meaning of the test and using this in clinical practice is very important and very important for the betterment of the patient. So thank you very much. And I invite Dr. Pawan for who will be introducing the another speaker.
Good evening, everybody. So I listened the talk very well. It's very interesting and very thoughtful talk. But meantime, I add on something. Meantime, we have to do some more testing, like PDL1 testing and DDMR testing, although it will be almost involved in the all testing or NGS testing, but it's very useful. And if we want to tumor burden mutation, then we have to a big or huge scale NGS study in this testing. So although in some cases they are very helpful to make the treatment decision in future, but still we have to do this testing also if there is a cost is not constrained. And now we move on after the panel discussion. Thank you, Akhil. So this panel discussion is end up here, and we move on some guest invitation lecture. And first is from Dr. Sunil Lokwani from consultant. He's a consultant and head of medical oncology in clinical hematology SCG Cancer Center in Indore, and he will be enlighten us with a new era integrating immunotherapy in LS non-small cell carcinoma. Dr. Sunil Lokwani, please.
Hello, sir. Thank you for inviting me to the talk. I thank Dr. Sandeep Jasuja as well for feeling the fact that he was my examiner and he gave me a degree to pass. And I really thank you, sir, for calling me up here. To proceed with, should I share my slides or should I ask the managing team to do so, sir?
So you share your slide. Hi, good evening, sir, to you. Please,
Hi,
if you can share your slides.
I'll just do that. Just a sec, please. Yeah. Is it visible?
Yes, sir. We can see you. We can hear you. If you can make it full screen and then all yours,
Yeah.
sir. Yeah, great.
Yeah. Thank you. Thank you very much for the help. So let's talk about limited stage small cell, a disease which was actually low in numbers and hence not much paid attention to. And something which always invariably came into the people who enjoyed life through smoking. So more or less, the element of what do you call a sympathy always was lacking in these kind of patients. So henceforth, the novel things which came in a bit late. Somewhat, I would say it was more or less a neglected kind of a disease. And just to talk around with the statistics part, it represents only 15% of all lung CAs. More than 50% or nearly 50% of all SCLCs do have brain mets. And the median age of presentation is quite late, that is 60 years roughly. But we do see younger patients as well in the age of 40s and 50s. So it exclusively occurs in smokers. So people who have really enjoyed their life in a whiff of smoke definitely do land up with SCLC. So there's a small slide mentioning a 12-year study or a review from a cancer center in North India. What they found out was around 27% of their presenting cases of CAs after the 361 studied were limited stage small cell and 73% were extensive stage. So limited stage and extensive stage have been used early since way long. The veteran system has been followed, and though our NCCN system is still in place, the TNM part is still in place. We largely use limited stage and extensive stage to classify according to our convenience and to classify the disease for management purposes. So when they were managing the limited stage diseases, most of them underwent chemotherapy. CTRT was given to only 25%. And what they quoted in the North Indian Institute was the median PFS was 169 days and the median was 190 days. So roughly over 6 months is what they commented on. So a lot of unmet needs were there in limited stage small cell lung cancer. And treatment outcomes do still remain poor. And something was at most needed to improve survival outcomes. Nearly 30% of patients with limited stage are alive at 5 years, so it's a very scarce data. And henceforth, something needed to come here and come in this space so that we can act something upon. We do have something in the modern world to tell, yes, something in SCLC we do have. So when we come to the classification, as I told you earlier, the Veteran Association classification of the LSG system classifies SCLC as limited or extensive disease. When you call something as limited, it is confined to one hemithorax, the lymph nodes are involved, pleural effusions independent of cytology are present, can be absent also. It is often confined to an area that can be encompassed within a radiation field and mostly corresponds to TNM staging of 1 to 3B. And any disease site beyond this is represented as an extensive stage disease, can be a contralateral disease, can be other nodes involved. So 1/3 of the cases are usually limited stage and roughly 2/3 are the extensive stage part. So disease classification is primarily to clinically exert the choice of treatment. When you have a limited stage, you either undergo a surgery if there is not too much nodes involved or not too much cutting out involved, and we have a fairly limited area that happens very less. If not that, then you go for a chemotherapy plus thoracic irradiation. And even after surgery, we do give some adjuvant treatment as well, followed by a prophylactic cranial irradiation that becomes mandated because we have seen most of the brain mets do come in small cell only. So that's why we do execute this part. There is no arguing on that part. When it comes to an extensive stage, you definitely go ahead with a combination immuno and chemo. That is a given nowadays. And if not, if there is a recurrence, there are questions to be answered. Subsequently, you give a platinum-based chemo and then any PCI. So I would like to state a few points here. Concurrent chemoradiotherapy in limited stage SCLC with cis-ETO combination, it's the preferred choice. For patients with a good PS, patients with a poor PS, sequential chemoradiation can be considered, although somewhat inferior in the PFS fraction, but can be given. Surgery followed by adjuvant chemo or concurrent CTRT is preferred for those eligible, but a very small minority of patients are eligible. So far, no currently approved targeted therapy in this space has been there. So when you have a CCRT treatment in a limited stage, what you do is cisplatin, etoposide, fosaicins plus RT. So this is what is usually given. We all are aware of this. It is preferred over sequential. Sequential can be considered for patients with poor PS, comorbids, or high disease burden. The idea behind PCI, more than 50% risk of brain mets is still there. It's still a viva question, I would say, or a practice question or something. It's an imperative thing which we discuss when we are talking about SCLC, the brain mets part. And as per guideline, also we do follow that MRI has to be carried out. Patient might have some asymptomatic mets, and it's a whole gamut and a whole basket, which is something completely different. And recommended for a limited stage is a good response, good PS, less than 60, you should go for a preferred clinical radiation. The use depends on clinical factors, patient factors, risk of neurotoxicity. It basically improves 3-year overall survival only 5% and cuts the risk of brain mets by nearly 50%. Coming to immunotherapy in small cell. So first line, extensive stage SCLC, you give either a combination of platinum with etoposide and durva, platinum with etoposide and atezo. That's a given. And based on different guidelines and different studies, we either label it as platinum refractory, chemorefractory, chemosensitive disease per se, depending on when it comes at a 3-month interval or 6-month interval. This is what all of us are aware of primarily. So I would like to discuss in the next 5-6 slides about a study, Adriatic study. It's a phase 3 randomized double-blind study, which is a multi-center study. What they did is they took patients with stage 1, 2, 3 limited stage SCLC, whose performance status was good. They had not progressed following chemo-RT, and prophylactic radiation was permitted before the randomization. So this is the whole inclusion part. They had given the treatment which was mandatory to be given. Subsequently, the patients were randomized in durvalumab versus placebo versus durvalumab plus tremelimumab arms. The idea was to check the OS and PFS primarily, as we need to do so. And what they followed it up for was for a long time. So this is a good data, good fraction which we have here. When you understand the baseline characteristics, more of the patients were towards the male side. If you understand the smoking status, most of them combined together were either current or former smokers. very few, extremely few population was never smoker population. And the baseline was matched across both the groups. Majority of patients did receive platinum and majority received once daily radiation therapy as the standard part. 53% of patients received prophylactic radiation trial in both arms. So when you come to the OS part was really surprising. It was the first and only immunotherapy. Durva showed a median OS of 55.9, it's 56 months, and a 3-year OS rate of roughly 56%. So it was something really shocking. The delta, if you can appreciate, is quite huge at 3 years, at 2 years, and it is really appreciable that Durva is definitely making a change even in the limited stage SCLC space. So the OS was consistent across all subgroups. If you can appreciate the forest plot, everything is tilting towards the left side. If you check the PFS part again, 16.6 months versus 9.2 on a placebo note, and a 2-year PFS rate of around 46%. Roughly 50% of patients in both areas had a good benefit, and a PFS of 16.6 months definitely takes the curve to tilt towards the immunotherapy. Again, if you check the forest plot, the PFS was consistent across all subgroups which were studied. Even the ones with prior PCI and with no prior PCI did respond well. And there was one question which was basically taken up here, whether in a limited stage SCLC, should you give a prophylactic irradiation or not? What they told us, there are several limitations. There is inclusion of small studies, there is heterogeneous population studied, randomized studies do lag. So what they want to point out here is there are 2 studies which are coming up, the Prima Lung study, which is still to come up, the results. And there is one recruited study, Maverick, which will definitely guide us in a better understanding of patients with limited stage SCLC, whether PCI should be given or not. And as per the subset analysis of this Adriatic study, the OS primarily was better or comparable to both the arms, whether you received a PCI or not. And similarly for PFS, irrespective of PCI, patients did have a better PFS. Frequency of adverse events were consistent, as is known for Durva per se. And in the patients being treated here, since they had received radiation pneumonitis was commonly seen as a side effect, so can be attributed to this. To conclude, treatment for a limited stage small cell should be given with a curative intent. And despite initially high response rates to CCRT, a long-term outcome remained poor. Concurrent CTRT is currently the standard of care, wherein we would like to pitch in Durvalumab, which is as a consolidation therapy after chemo-RT. It showed statistical significant, clinically meaningful improvement in OS and PFS, which I mentioned earlier. And it was tolerated up to 2 years, and safety findings were consistent with known safety profile. So, Adriatic study does make a benchmark in patients with limited stage SCLC and should be executed as a plan for consolidation for patients after completion of treatment. Thank you. That was my lecture. Thanks a lot for being listening to me.
Thank you,
I think I'll stop
thank
my
you,
share.
Dr. Sunitza, for such a wonderful presentation. Maybe if
Thank you.
anyone has a question, so can we use the chat box for that, because we are running
Yeah.
short of time.
Sure.
Dr. JB sir, are you there? If you can invite the next speaker. Are you there, sir? Okay, so this is again a sponsored talk, and it's a pleasure to welcome and invite Dr. Deepak Shukla sir from Jaipur, a senior consultant medical oncologist from the prestigious Manipal Hospital, Jaipur. It's a sponsored talk, and we request to Dr. Deepak Shukla sir to present his slides. He's going to present on a new breakthrough in the first-line management of ALK rearranged NSCLC. So over to you, Dr. Deepak Shukla sir. Can you hear us, sir?
Yes, I can hear. Thank you, Tarun. I'll like to share my slides. Just wait for a minute. Are you able to see this?
Yes, we can see the slides. We can hear you well. We can see the slides. Over to you.
Sorry. Yeah, just a moment.
Yeah.
Is it okay now? Full view?
Yes, sir. Yes, sir. Yes, sir.
Okay.
Yes, sir.
So Thank you, Sandeep sir. I'll be going to speak on the topic new breakthrough in the first line management of ALK positive non-small cell lung cancer. So the ALK was a target or a fusion that was discovered in 2007 in Japan. And starting from 2012 with crizotinib being approved based on the profile data to the third generation lorlatinib based on the CROWN data, what we have seen across the generation is that there is increasing activity against ALK across the generation, broader coverage of ALK resistance mutation, and improved penetration into the CNS. What has been also clear from the data from the retrospective data set and also from the prospective data set is that close to 25% patients never get second line treatment. Also, even with the patients who are being treated on second generation ALK inhibitor, close to 20% of the patients go on to develop brain mets in spite receiving a second generation ALK inhibitor. So how do you decide first line therapy for advanced ALK positive non-small cell lung cancer? So these are few factors starting from response rate, progression-free survival, overall efficacy, CNS activity, OS, and what's available in second line toxicity, and possibly what is not mentioned and often is the most important criteria in clinical practice is cost and the panel which drug is approved under it. But leaving that aside, let's discuss the CROWN data, which was a phase 3 trial which compared the third generation ALK inhibitor lorlatinib to the then standard of care crizotinib in patients with advanced ALK positive non-small cell lung cancer who have not received any prior systemic treatment, and patients who are having asymptomatic treated or untreated CNS mets were also enrolled in this trial, and the PFS was the primary endpoint. At the interim analysis presented at 18.3 months, median follow-up lorlatinib arm did not reach a median PFS, while it was 9.3 months in crizotinib arm, leading to close to 72% risk reduction in death or progression with lorlatinib. And at subsequent post-hoc analysis at 3 years, again, the median PFS was not reached with lorlatinib, while it was 9.3 months with a hazard ratio of 0.27 in favor of lorlatinib. These are a few options one may consider as an alternate to lorlatinib. And as we see the hazard ratio for lorlatinib with median PFS not being reached at 36.7 months and hazard ratio being 0.19, if we consider the alternate, suppose if we start with alectinib, possibly we may get something close to 34 to 25 months. And even if we give at progression, which 25% patients do not get an option of getting lorlatinib, the benefit will be a little bit close to 5.5 months. And also similar data with brigatinib. So if we see, though it is a cross-trial comparison, but again, the PFS that we achieve by giving first-line lorlatinib is much compared to sequencing other second-generation ALK inhibitor followed by the third-generation ALK inhibitor. The 5-year analysis efficacy of the CROWN data showed that at 60 months, close to 60% patients were progression-free with lorlatinib, which is a delta close to 52% as compared to crizotinib, where only 8% patients were progression-free with a hazard ratio of 0.19 in favor of lorlatinib. The overall response rate was 81% in favor of lorlatinib as compared to 63% with crizotinib, with a CR rate of 10% with lorlatinib. What is equally impressive is the activity of lorlatinib in patients with or without baseline brain mets. So even with baseline brain mets, 53% patients were progression-free with lorlatinib, while none of the patients were progression-free with crizotinib. While in patients without baseline brain metastasis, there was 53% difference as compared to crizotinib with lorlatinib, with close to 63% being progression-free at 60 months. The data is equally impressive for the Asian subset, and at 60 months, 63% patients are progression-free. If we look into the various subgroups, across the subgroups, there is clear benefit of addition of or giving lorlatinib. If we look into the brain metastasis population, the hazard ratio is even more impressive if patient is having brain mets as compared to without brain mets. And if we compare the hazard ratio of 0.08 in patients with brain mets and 0.24 and compare it with the LX data, the hazard ratio is much better as compared to alectinib data. This slide shows the improvement that we have seen over the last 10 to 15 years. So when crizotinib was tried, it improved the PFS by 2 times as compared to chemotherapy. Subsequently, as compared to crizotinib, the second generation ALK inhibitor improved the PFS by more than close to 2 times. And now with the third generation ALK inhibitor, lorlatinib, we have still the median PFS has not reached. It is more than 60 months with a hazard ratio of 0.19. If we compare the PFS and OS debate of lorlatinib with the brigatinib or alectinib, the 5-year OS reported with ELTA-1L is 62.5%, while the PFS itself is close to 60% with lorlatinib. In the pivotal lorlatinib phase 1-2 study, at the median follow-up of close to 6 years, median overall survival still has not reached. The 5-year overall survival was close to 76% in treatment-naive patient, and OS follow-up is currently ongoing. If you compare this data with the 5-year OS data of 62% and 66% respectively with alectinib and brigatinib. So one may argue, do we need to wait till the data becomes mature, where the estimate could be that median PFS may reach up to 10 years, and possibly we must give the best option first up. So lorlatinib also delayed intracranial progression versus crizotinib. There was no intracranial progression events after initial 3 years. Also, patients, close to 4% patients without baseline brain metastasis had CNS failure in first 16 months, and beyond that, there were no CNS progression seen with lorlatinib. The 5-year follow-up data showed that the overall response rate is close to 81% with a CR rate of close to 10%. And if we compare it, the complete intracranial response rate, it is close to 60%. And what we have seen with LX data, it is close to 38% with alectinib. So much more impressive data and durable responses with the lorlatinib. So coming to the subgroup analysis, we know the ALK variant 3AB and the P53 mutated ALK positive disease is having an aggressive biology, and the PFS reported with both the first and second generation ALK inhibitor is low. But with lorlatinib, even with these variant and P53 mutation, the median PFS is close to 60 months with lorlatinib, and in P53 mutated, it was 51.6 months with a hazard ratio clearly favoring lorlatinib. Coming to the safety and therapy management, so what we know from the CROWN data set that 23% patients require dose reduction. Temporary discontinuation was 62%, but what is good to know that the permanent discontinuation rate was low. It was close to 11%. And if we compare the data across the various first-line trial, the adverse event leading to treatment discontinuation seems to be low. And as mentioned, it is close to 11% in the CROWN data set. If we look into the all causality adverse events occurring in more than 10% of the population, The most common grade 3-4 adverse event in lorlatinib treatment group were hypertriglyceridemia, increased weight, hypercholesterolemia, and hypertension, while the vision disorder and GI side effects were more commonly seen with crizotinib. This is the timeline and the median time to onset and duration of adverse reaction with lorlatinib. So to begin with, one must be careful once we start lorlatinib that hyperlipidemia, the median onset is day 15, and duration of these metabolic side effect could be more than a year. It is followed by edema, which is as an onset of day 42, median duration close to 163 days, peripheral neuropathy day 105, weight increase at 112 days. The below mentioned is duration is the median. This may take so much median time to either control or to stabilize. The CNS side effect, the earliest to begin within the second month could be mood effects, psychotic effects will follow, and speech effects. Later down the line at around day 155 in the 6-month timeline, patient may go on to develop cognitive side effects. And the patients, once they are being started, there should be a careful discussion discussing these side effects so they can inform us if any side effect is present. So coming to the hyperlipidemia part, 72% of the patients experience hypercholesterolemia, 66% of the patients experience hypertriglyceridemia. 1% of the patients who experience hyperlipidemia discontinue treatment. But what was reassuring that the incidence of cardiovascular events was lower in lorlatinib than crizotinib among patients with hyperlipidemia at baseline or who developed hyperlipidemia during study. And the CNS adverse reaction, as already mentioned, mood, cognition, speech, psychosis, were experienced by close to 42% patients, and 2% of the patients who experienced CNS adverse reaction discontinued treatment. 57% of the patients experienced edema, 44% experienced weight gain, and no patient discontinued treatment. However, they required dose reduction in 1% of the population. So the hypercholesterolemia and hypertriglyceridemia, as discussed, was observed in majority of the patients treated with lorlatinib. Most of these hyperlipidemia events were managed and controlled with the use of lipid-lowering agents, particularly pitavastatin, pravastatin, and rosuvastatin should initially be considered based on the low involvement of cytochrome 3A4. And majority were resolved by using medication, and few of them even required no intervention. The frequency and severity of CNS adverse events were in line with the prior analysis, and majority of these CNS adverse events were grade 1 and 2, and only 3 patients in the lorlatinib arm permanently discontinued lorlatinib due to CNS adverse events. As mentioned, close to 40 to 45% had some form of CNS adverse event, the most common being cognitive, followed by mood effects, speech effects, and psychotic effects were there. And as most of these CNS adverse event does not require medical intervention, and they could be managed very well by using, if required, psychiatric and neurology help once they develop. The most important part in the management of this drug is to treat the hyperlipidemia. So one must be aware that it is the most common initial side effect that majority of the patients will get. So starting from 2 weeks to 1 month timeline, start measuring the lipid levels. If lipid levels are normal, continue the drug and continue to monitor lipid levels. If the lipid levels are elevated and the total cholesterol is below 500 and triglyceride level between 150 to 1000, either we can begin the dose of statin, or we can increase the dose and continue the treatment. But if a patient go on to develop life-threatening elevated lipid levels, that is defined by total cholesterol greater than 500 or triglyceride levels more than 1000, then it's the time to stop the drug. increase the statin medication, keep endocrinologist or cardiologist in loop. And in spite of giving the maximal dose of lipid lowering agents, we are not able to control the side effect, then possibly it is time to reduce the dose from 100 milligram by 25 milligram and giving at a 75 milligram dose. And as discussed previously, close to less than 2% patients need to discontinue this drug because of this side effect. Coming to the other side effects, weight gain, this will require lifestyle modification, diet restriction, and discussion with the patient. Simple measures can be taken, and the edema part could be tackled by leg elevation, giving diuretic, but with careful electrolyte monitoring. And if at all these are not controlled, then possibly later on one can consider dose reduction. Peripheral neuropathy, majority of the cases, it is grade 1 or grade 2. And the management is by supportive treatment. We can give pregabalin, gabapentin, continue with the drugs. If at all it fails to respond, then time to pause. And if at all it is not controlled, then only we have to reduce the dose. The CNS side effects, as discussed, develop early. They tend to resolve earlier as compared to the other side effects, but the recognition of these CNS side effects like mood, cognition, speech difficulty, word finding difficulty, any change in behavior, they should be informed to the patients, and early stoppage and careful discussion with the other specialist, and then restarting the drug, possibly at the same dose or lesser dose could be given. And this could be a reason to stop the treatment, but in a very few of the patients. And what is encouraging to note that even in patients who had dose reduction, the PFS and the intracranial progression was not an issue. The drug works even at a lower dose. So in my mind, based on the data, updated data from 5 years from the Crown, either combination of second generation or first generation followed by third generation is not should not be the logical choice until unless some other issues like are there, like some comorbid illness or finance, and possibly lorlatinib should be the first line treatment. It has shown a hazard ratio of 0.19. That is very impressive, with 60% patient being alive at 60 months. Thank you.
Thank you so much. Thank you, sir, for such an enlightening presentation. We request you to stay back. You might have some questions on the chat box. We move forward, and it's a pleasure to welcome and invite Dr. Deepak Gupta, sir. Good evening, Dr. Deepak Gupta, sir. He's a now Additional Director, Medical Oncology from the prestigious Bhagwan Mahavir Cancer Research Institute, Jaipur. And Dr. Deepak, sir, is going to talk about the lung cancer session, redefining the management of NSCLC with atezolizumab now and next. So, Dr. Deepak, sir, the stage is yours. If you could just share your slides, please. Hello, Dr. Deepak Gupta, sir.
Yeah, good evening. Yeah, good evening. Can you see my slide?
Yeah, good evening. Oh, pardon, sir. So you need to share your slides, sir.
Okay, I shared it.
So we can see your slides perfect, and we can hear you well. And if you can just deliver your presentation.
So good evening, everyone. So today's topic is to speak to is redefining the management of NSCLC with atezolizumab now and next. So as you all know, the first line treatment options in metastatic NSCLCs are either chemotherapy or with anti-angiogenic agent, or in combination with immunotherapy or immunotherapy doublet only. But in second line treatment, immunotherapy is only used if it is not used in first line. So these are the NSCLCs approval in first line, second line metastatic NSCLCs based on various trials. Like I will discuss, like IM Power 1110, which was single agent atezolizumab as compared to chemotherapy in both squamous and adeno. Second one is IMpower 130 for adenocarcinoma to assess the atezolizumab with the steroid sparing chemotherapy with nab-paclitaxel. And third is IMpower 150, which is also again in adenocarcinoma with atezolizumab with bevacizumab with chemotherapy, which is ABCP regime. So coming to first trial, IMpower 1110. So this was the to assess the atezolizumab monotherapy as compared to chemotherapy in PDL1 selected first line NSCLC's patients. So all stage 4 non-squamous or squamous, but chemotherapy naive and PDL1 selective EGFR and ALK negative patients were included. So they were randomized 1:1 to atezolizumab 1200 milligram every 3 weeks, followed by maintenance of atezolizumab or non-squamous or chemotherapy as per the histology like pemetrexed carboplatin or gemcitabine carboplatin, followed by maintenance either pemetrexed in adeno or best supportive care until progression. So primary endpoint of overall survival in PDL1 high expression subgroup was met with a median OS of 20.2 months with atezolizumab as compared to 13.1 months, with a difference of 7 months in OS. And as far as PFS is concerned, the median PFS was 8.2 months as compared to 5.0 with a hazard ratio of 0.59 in this all in PDL high subgroup. And updated analysis of high PDL subgroup, overall response rates are 40% as compared to 28% with chemotherapy. So they also tested, compared the biomarker assays like SP142, SP263 with 22C3, and there was no difference in response rates to atezolizumab. So they were all equivalent. These are the toxicities with atezolizumab. So you can see most of the toxicities are seen with chemotherapy like anemia, nausea, neutropenia, thrombocytopenia, vomitings, fever. But the class effect of immunotherapy like rash and arthralgia, pruritus, hypothyroidism are seen more commonly with atezolizumab. So this was a positive study that demonstrated statistically significant and clinically meaningful improvement of overall survival in high PDL subgroup wild type population versus platinum-based chemotherapy with a hazard ratio of 0.59. And safety profile of atezolizumab was consistent with prior observations. No new or unexpected safety signal was identified. Second study is IMpower 130, which is again in adenocarcinoma. Phase 3 study of carboplatin and nab-paclitaxel with or without atezolizumab in first line advanced non-squamous NSCLCs. So patients were randomized into 2:1 fashion to arm A, which is atezolizumab plus nab-paclitaxel and carboplatin, 4 to 6 cycles, followed by maintenance of atezolizumab until disease progression. And arm B was carboplatin plus nab-paclitaxel, followed by either best supportive care or pemetrexed maintenance, switch maintenance. So nab-paclitaxel is potentially steroid sparing because conventional paclitaxel is formulated in solvent Primafor, which requires steroids to prevent hypersensitivity reactions. And steroids are potentially immunosuppressive and may reduce the efficacy of immunotherapy. Nab-paclitaxel is solvent-free formulation, does not require steroids. These are the baseline characteristics. Approximately 50% of patients were PDL1 negative, 20% were PDL1 high, and 30% were PDL1 intermediate. So investigator assessed PFS was significantly improved with addition of atezolizumab to chemotherapy. Median PFS was 7 months with atezolizumab based treatment versus 5.5 months with chemotherapy alone, and hazard ratio was 0.64. In forest plot also, PFS benefit was observed across all clinically relevant subgroups irrespective of PDL1 or liver metastasis, smoking history. OS was also significantly improved with addition of atezolizumab to nab-paclitaxel and carboplatin. Median OS was 18.6 months with atezolizumab based combination as compared to 13.9 months with chemotherapy alone. And OS was also significantly better in all clinically relevant subgroup as it was seen with PFS. Overall response rates and duration of response were also improved with the addition of atezolizumab to chemotherapy. You can see in this 49% response rates with addition of atezolizumab as compared to 31% with chemotherapy. Most of them were PR only, and few, approximately 1/3 were stable disease. So in this trial, IM power 130, it met its co-primary endpoint of PFS and OS endpoints and demonstrated a statistically significant and clinically meaningful benefit of 4.7 month in OS and 1.5 month of PFS for atezo plus chemotherapy in ITT wild type population compared with chemotherapy alone. And it was observed across all PD-L1 subgroups. Atezo plus chemotherapy had a safety profile consistent with adverse event associated with single agent therapy, and no new safety signals were identified. IM power 130 results support atezo plus chemotherapy as a treatment option for patients with advanced non-squamous NSCLCs. Now coming to third study, which is IM power 150. It is also in adenocarcinoma, and phase 3 study of atezolizumab plus chemotherapy and bevacizumab in first line advanced NSCLCs. So in this trial, patients were randomized into 3 arms. Arm A was atezolizumab with carboplatin and paclitaxel. Arm B was atezolizumab, carboplatin, paclitaxel, and bevacizumab. And arm C, which is considered control arm, was bevacizumab with paclitaxel and carboplatin. These all were given 4 to 6 cycles and followed by maintenance of either atezolizumab or bevacizumab or combination as per the treatment arm. And it was continued until disease progression. So these are the baseline characteristics which are well balanced between 2 arms. 14% of patients had liver metastasis at baseline. 10% were EGFR mutation positive, and approximately 50-50 split between PD-L1 positive and PD-L1 negative population. So the main comparison is between arm B and arm C, that is ABCP and BCP regime. So with ABCP, median OS was 19.5 months as compared to 14.7 months with bevacizumab, which means addition of atezolizumab to conventional BCP regime leads to improvement in overall survival with a hazard ratio of 0.80. Overall response rates and duration of response was also improved in intent to treat population. With arm B, it was 56% response rates, while arm C had 41% of response rates. In PD-L1 high subgroup, response rates further increased to 69% as compared to 49% with chemotherapy BCP regime. In PD-L1 low or PD-L1 negative group also, the response rates were better with ABCP regime as compared to BCP regime. Median duration of response was 11.5 months with ABCP, and it was 6 months with BCP regime. In OS benefit was observed across all PD-L1 subgroups in arm B versus arm C. In PD-L1 high subgroup, the median OS was 30 months as compared to 15 months only with BCP regime, with a hazard ratio of 0.70. And if you see in PD-L1 negative group, that is no expression of PD-L1, there was no difference in ABCP versus BCP arm. While in PD-L1 positive, either low positive, intermediate positive, or high positive, the benefit of atezolizumab was maintained in all 3 subgroups, 22.5 months as compared to 16 months with BCP regime. Now, efficacy in key subgroups like EGFR positive patient who have already received EGFR TKIs and they have progressed on EGFR TKI. So clinically meaningful PFS benefit was observed for arm B versus arm C in EGFR mutated or ALK positive NSCLCs. Curve started separating at around 6 months. Median PFS was 9.7 months as compared to 6.1 months with conventional chemotherapy, and it was statistically significant with a hazard ratio of 0.76. 0.59. OS benefit was also seen in patients with EGFR mutated patients with a hazard ratio of 0.6, which is as good as PFS. And the median OS was 29.4 months as compared to 18.1 months with chemotherapy. This is arm B versus arm C. But if we compared arm A versus arm C, which is BCP versus ACP, there was no difference was seen. Overall response rates and duration of response was also improved with combination of BCP, ABCP, with 71% response rates as compared to only 42% with BCP regime, and CR rate was 6% in ABCP regime, which was 0% in BCP. Now, another key subgroup is of liver metastasis. So, clinically meaningful PFS was benefit was observed for arm B as compared to arm C. Median PFS of 8.2 months versus 5.4 months with BCP regime, and the hazard ratio is highly significant of 0.41. OS benefit was also seen in liver metastasis subgroup, which is considered a poor prognostic subgroup, and with a median OS of 13.2 months as compared to 9.1 months with arms B versus arm C. But in arm A versus arm C, there was no difference. Again, the response rates was again superior as with ABCP regime, 60.8% as compared to 41% with BCP regime, and median duration of response was almost more than double, 10.7 months as compared to 4.6 months with BCP regime. So to summarize, IMpower 110, it is for atezolizumab monotherapy in high PD-L1 expression, both squamous and non-squamous histology. And IMpower 130 is for atezolizumab plus steroid sparing, carboplatin and nab-paclitaxel chemotherapy in non-squamous histology. And all PD-L1, all comers were included, even less than 1% also. And this is an option in patient with comorbid conditions like uncontrolled diabetes, where steroid is contraindicated. IMpower 150, which compared 4-drug combination of ABCP in non-squamous histology. All PD-L1, all comers were included, and significant benefit was seen in those who have progressed on TKIs, EGFR or ALK TKIs, liver metastasis, and bulky disease also. Thank you very much for your kind attention.
So thank you so much, Dr. Deepak Gupta sir, for enlightening us for all three studies. Great, and thank you so much for spending time with us. I think you might have some questions coming up in that chat box. We move forward, and again, this is a sponsored talk. We have a pleasure to welcome and invite Dr. Shrikant Tiwari, sir. He is a senior consultant medical oncology at prestigious Sagar Multi-Specialty Hospital, Bhopal. Very good evening to you, sir. And we are going to talk on the advanced EGFR mutant NSCLC evidence-based review of targeted therapies. So, Dr. Tiwari, sir, over to you. We are eager to listen to you, sir. Can you hear us, please?
Yes, yes. Thank you, Tarun Mathurji and all the organizing team. Good evening to all the participants and the audience. Just let me share my slides.
Yashoka, can you allow Dr. Shrikant sir to share the screen?
Let me try by myself.
Yes.
So sir, I have already disappeared the slides.
No. You still looks to be there.
Sorry, what you're saying?
Yeah, Shrikant sir, now we can see you well. If you can share your screen, please.
Okay. Just give me a time. Okay. Just a minute. Screen. Just a minute. Give me a second. Sharing my screen. Okay. Is the screen visible?
Absolutely, sir. Screen is visible, you're audible, and over to you, sir. Make it full screen and over to you, sir.
Okay. So, my topic of presentation is just a minute. Yeah. So my topic of presentation is minimize here. So, evidence-based review of the targeted therapy in advanced EGFR mutant NSCLC patients. So, the slide is moving now.
Next, the slides are not moving. You need to make it full screen.
Yeah, I have done it full screen. It is visible on my laptop. It is visible.
Acha, Yashika, can you help? Sir, the slides are moving, but it's not coming as a full screen. Okay, you go ahead, sir.
Okay. Is it moving now?
So the slides are moving, but can you please make it full screen?
It is. I have made it full screen. I've already made it full screen.
So let me present from our side. Can you just in second?
So you can do stop sharing. Now Yashika, my colleague, will share. You just say slide next, next, and next.
Okay, I have stopped sharing.
So you're on the slide 1. You can start now, sir.
Yeah. So can you make it full screen? It's not visible to me for full screen. Okay, that's fine now. Okay, so can you go for the previous slide? Jessica, please go on the previous slide. Previous, please, previous. Yeah. So the topic of my presentation is the evidence-based review of the targeted therapy in advanced EGFR mutant NSCLC patients. Next, please. Next, please. Yeah. So to begin with the epidemiology, globally, it is lung cancer is the second most common cancer which is diagnosed in male and third most common in female. But if you see the mortality wise, it is still the number one cause of cancer-related mortality in male and number 2 in female. If you talk about the India, it is the 4th leading cause of cancer death, both in incidence wise as well as the mortality wise also, in both male and female. As we know, the NSCLC is the most common type of lung cancer. Next, please. So, if you see the diagnosis at stage wise, almost 90 to 95% of lung cancers, especially NSCLC, is diagnosed in locally advanced or advanced stage. So, in a stage 3, 29.1% of patients diagnosed in stage 3, whereas 65.9% of patients diagnosed in stage 4. Where in early stage, only 3 to 5% of patients diagnosed in early stage. If you see the 5-year survival data for NSCLC, in a stage 1, the 5-year survival data is around 70 to 90%. In a stage 2, it is around 50 to 70%. In a stage 3, including a stage 3, A, B, and C, it is around 10 to 30%. But if you see the survival data, 5-year OS data of stage 4, it is less than 50%, less than 10%. Next, please. So, when we evaluate the NSCLC, it has been seen that more than 50% of stage 4 NSCLC have certain type of biomarkers. Basically, 2 type of biomarkers we use to estimate. One is the predictive biomarkers, which are indicative of the therapeutic efficacies because there is an interaction between the biomarkers and therapy on the patient's outcome. And the second is the prognostic biomarkers, which are indicative of the patient's survival, which is independent of the treatment patient receives. So, testing for the several genetic mutations as well as the PD-L1 status is recommended for patients who are having advanced NSCLC to determine whether such type of patients can be benefited for such type of targetable agent or not. The common type of targeted mutations which is seen in NSCLC patients are the KRAS, EGFR, ALK rearrangement, HER2 mutations, BRAF, PIK3 mutations, MET amplification, MYC1. But the most common one is the KRAS, EGFR mutation, and ALK mutations. We are focusing on EGFR mutations. Next, please. There are certain methodology for the testing of such type of mutations. Like for EGFR, the PCR-based assay is more important. It is approved. For ALK and ROS, the FISH test is enough. It is approved. And for PDL1, IHC testing is approved. Next, please. The EGFR driver mutation in lung cancer, the most common type of EGFR mutation is seen in the exon 19 as well as in the exon 20. In exon 19, most common mutation is in the exon 19 deletion, whereas in exon 21, it is most common is the point mutations. The most common point mutation is L858R. Apart from these most common mutations, there may be a mutations in exon 18 as well as in exon 20 also. If such type of mutations are positive, such mutations are sensitive to EGFR TKI. Next. So based on the limited number of studies, it has been seen that the prevalence of these EGFR mutations is broadly similar across the disease. So if you see the Asian populations, whether it is stage 1, 2, or 3, or stage 4, the range of this EGFR mutation is around 30% to 50%. So in Asian populations, the median incidence, the prevalence of this EGFR mutation is around 30 to 40%. Then in Caucasians, the prevalence is little lesser. It is around 10 to 20%. Next. The NCCN guideline also recommended that in patients of advanced NSCLC, whether it's the squamous cell carcinoma or non-squamous cell carcinoma, the EGFR mutation should be tested because it has been seen that in those patients in whom the EGFR mutations are not harboring, such type of patients should not be treated with empirically with EGFR TKI because there is no benefit of such type of treatments. Next, please. So how this pathway work in those person if the EGFR is wild type? In such type of cases, the downstream signaling pathway is only activated when the EGF ligand is bind to this EGF receptors. Once this EGF ligand bind to this receptor, then it leads to dimerization and the activation of this tyrosine kinase, and then the downstream signaling pathway became activated. But in those patients in whom the EGFR mutations are there is autonomous method where the continuous dimerization and downstream signaling pathway continuously activated, and that leads to the cell survival, cell proliferation, and metastasis of the disease. Next, please. This is the current treatment option for advanced lung cancer. So for those patients who are having EGFR mutations, the options of the treatments are whether the patients can be used the first generation TKI, second generation TKI, or third generation TKI, that is osimertinib, or this now we are using along with this TKI, we can use this chemotherapy or anti-VEGF therapy can be used as a first line therapy. The preferred one is the osimertinib. Next, please. So the benefit of the this osimertinib is that it's not only act on the common mutation, that is the exon 21 deletion or 21 mutations or exon 19 deletion, but also it act on the if the T790M mutation is there. So it is the only EGFR TKI which also act on if the patient is having showing T790M mutations. Next, please. So the FLORA trial, next please, on the basis of which this osimertinib has been approved. Next. So the FLORA trial was a phase 3 double-blind study which was conducted across the 132 cities in 29 countries. And the patients included were locally advanced and metastatic NSCLC. The key inclusion criteria were those patients who have exon 19 deletion or exon 21 point mutations, who have not received prior systemic therapy or any anti-EGFR TKI. The stable CNS metastasis was allowed in this study, and stratification was done on the basis of whether the patient is having exon 19 deletion or 21 point mutation, and on the basis of race. The randomization was 1:1. In treatment arm, patient receive osimertinib 80 milligram once daily, and in comparator arm, patient receive either gefitinib or erlotinib with respective dose. The crossover was allowed in the study, so those patients in comparator who progress or those who develop T719M mutations, they cross over to the treatment arm, that is osimertinib. The primary endpoint of this study was the PFS, and the secondary endpoint was the objective response rate, duration of response, and safety profile. This is the baseline characteristics of the treatment arm and comparator arm. The both arm are well balanced. Both arm includes almost similar type of profile of patients. Next. Now, if you see the PFS by investigator assessment, the median PFS in case of osimertinib is around 18.9 months, whereas in comparator TKI, it is 10.2 months. So the median PFS in case of osimertinib is almost double to that of comparator TKI. And osimertinib reduces the risk of progression or death by 54% compared to this standard comparator TKI. Next. If you see the forest plot, the benefit is seen across all the predefined subgroups, whether the patient is having male, female, smoker, non-smoker, irrespective of the race. Although the benefit is more in non-Asian populations compared to the Asian populations. The benefit is also seen irrespective of which type of mutations is there, whether it is exon 19 mutation or L58R mutations are there. So benefit is seen across all the subgroup of patients. Objective response rate, the duration of response, median duration of response is around 17.2 months in favor of osimertinib, whereas the standard TKI, it is 8.5 months. So again, the duration of response is almost double in favor of osimertinib. And if you see the separation of curve, the separation of the curve has been separated as early as 2 months before. And as the time elapsed, the curve became more and more widened. So the osimertinib leads to an early response, more deeper response, and even more durable response in compared to this comparator EGFR TKI. Next. The OS data, the final analysis was done on 58% maturity. And if you see the median OS with osimertinib, it is around 38.6 months. With comparator EGFR TKI, it is around 31.8 months. So this final analysis of OS demonstrated a clinically meaningful and statistically significant improvement in overall survival with osimertinib in compared to comparator TKI. Next. Next, please. Now, adverse effect. Just before, the adverse effect, the median exposure of osimertinib is around 20.7 months, whereas the comparator TKI is only around 11.5 months. And if you see the adverse effect profile, that is diarrhea, skin changes, or the elevation of this liver enzyme, almost all the adverse effects is seen more in favor of this osimertinib. So the safety profile of osimertinib is almost comparable to that of comparator EGFR TKI. Next, please. And if you see the adverse effects that lead to discontinuation of treatment, the discontinuation of treatment is seen is only 13.3% of patients in osimertinib group, whereas in comparator EGFR TKI group, it is around 18.1% of patients. Next. So to summarize this FLORA study, the osimertinib resulted in the highly statistically significant and clinically meaningful improvement in the PFS over the this comparator TKI. There was a significant and clinically meaningful improvement in the CNS PFS also seen over this comparator TKI. The final analysis of overall survival resulted saw a promising survival trends which is favoring osimertinib, and the safety profile is almost comparable to that of this comparator TKI. Next. The CNS efficacy of osimertinib. Next, please.
Dr. Shekhar sir, you have last 1 minute to conclude. So
just give me 2 minutes. So it has been seen that those patients who are having EGFR mutations, the tendency of having brain metastasis is higher in compared to those patients who are having EGFR wild type. Next, please. Next, please. Next, please. Yeah, so if you see the PFS in those patients who are having with or without CNS metastasis at baseline, so those patients who are having with CNS metastasis, median PFS is around 15.2 months, where in those patients who are having without CNS metastasis, the median PFS with osimertinib is around 18.9 months. Next. Go a little faster, please. So CNS PFS activity in CNS full analysis in those patients who have been CNS metastasis is there. The median PFS has not reached with the osimertinib, whereas in case of competitor TKI, it is around 13.9 months with the hazard ratio of 0.48. Next, please. Now, there was no direct head-to-head comparison has been done with the osimertinib versus the second generation EGFR TKIs, that is decomitinib and afatinib, but the data wise we can analyze. Next, please. So if you see the data of this Archer 1050 trial for decomitinib, the median PFS is around 14.7 months. And if you see the separation of curve, it took 6 months to separate the curve apart. So the duration of response is neither the duration of response is very durable, nor the response is very early. Whereas if you see the data of this osimertinib of FLORA trial, the curve is separated as early. So that means the duration of response is more, the depth of response is more deeper, as well as the response occurs more early in osimertinib in compared to this decomitinib. Next, please. There is no OS data for this Archer 1050 trial, whereas next, please. For osimertinib, there is OS data and next, please. Median OS is around 38.6 months. Next. Go next. For afatinib, again, the median OS data is not there for afatinib. And if you see the median PFS data, it is around 11 months for afatinib versus 10.9 months for gefitinib. Next, please. Again, the co-primary endpoint survival was not seen with the afatinib. It was around 27.9 months versus 24.5 months. Next. So on subgroup analysis, it is also seen that for exon 19 deletion or exon 21 point mutation, there was no OS advantage was seen for afatinib in compared to the gefitinib or erlotinib. Next. The safety profile, if you see these all three landmark trials, the osimertinib is well tolerated, and it is much more safety profile is much more in favor of osimertinib in compared to afatinib and decomitinib, and therefore the dose reduction is required in only 5.4% of patient of osimertinib, where it is dose reduction is required in 42% of patient of afatinib, and in decomitinib 66% of required dose reduction at certain point of time. Next, please. Next, please. Yeah. So when we come to the sequencing, how we should start or how we should sequence, because 3 generation of EGFR TKI is available. This FLORA study has resolved the this dilemma of sequencing, and now the osimertinib has been the preferred first-line treatment for EGFR mutant NSCLC patients. Next, please. Go next. So what will happen if this osimertinib has been used in second line? If you see osimertinib has used in second line, and if you are using first generation or second generation EGFR TKI in the first line setting, in that case, it has been seen that around 30 to 40% patients were not able to receive the second line of treatment. And those patients who have received treatment, osimertinib will be benefited only in those patients who have shown T790M mutations. Next, please. Next. And therefore the NCCN guideline also, although almost all the EGFR TKI either alone or along with the chemotherapy or anti-VEGF therapy are kept under category 1 recommendation, but the osimertinib is the preferred recommendation. Next. So to conclude, for the first time in the evolution of this EGFR TKI, osimertinib has shown the translation of the PFS into the significant OS benefit. The osimertinib has a median PFS of around 18.9 months with a median OS of around 38.6 months. It has shown the efficacy on those patients who are having CNS metastasis. There are fewer CNS progression events has been observed in those patients who are on the osimertinib compared to other competitor EGFR TKI. The fewer or less adverse effect is seen with osimertinib, so it is better tolerated. So now osimertinib is a new standard of care in those patients who are having EGFR mutant advanced NSCLC patients. Next, please. Thank you.
Thank you, sir. Thank you so much for this elaborate presentation. I'm sorry there might be some questions in the chat box, and since we're running short of time, thank you so much all the speakers as well as the chairperson for conducting the session one, which was on the lung cancer. Now it's a great pleasure to welcome and invite our next chairpersons, the eminent Professor Smita Jain, ma'am. Good evening to you, Doctor. Thank you so much for joining. Ma'am is a very reputed surgeon and oncologist. Now she is a principal and controller at the Government Medical College, DASA, ex-PhD Department of Surgery, SMS Medical College, Jaipur. Dr. Smita Jain, ma'am, good evening to you. Thank you so much for joining. Hope you're there. Uh, and we also have Dr. Hemam Dani, sir, Senior Medical Oncologist from Sudha Hospital Medical Research Center, Kota. And also co-chairing is Dr. Mukesh Sonalia, Assistant Professor, Medical Oncologist and Hemato-Oncologist, State Cancer Institute, SMS Hospital, Jaipur. So we request the respected chairperson to invite the first speaker. Sumita Jain, ma'am, can we request you to invite the next speaker, please?
Am I audible? Am I audible?
हाँ जी डॉक्टर साहब we are audible पर ऐसा लग रहा है कि अब in a two device.
No, my device is only one.
अच्छा, okay.
Yeah, I guess.
Yeah,
I'm on
so you
laptop.
can invite the first speaker.
Yeah. So good evening, everyone. This session is dedicated to breast cancer. As we all know, the approach to early breast cancer has evolved rapidly in recent years because of availability of many therapies, chemotherapy, immunotherapy, biological therapy, targeted therapy. But the challenge is which therapy to which patient. To throw light on this important aspect, I invite the first speaker of this session, that is Dr. Manoj Mahajan, who is Director of Oncology Service at Pacific Medical College, New Delhi. Over to Dr. Manoj Mahajan.
Am I audible?
Yes, Dr. Mahajan.
Yes. Thank you, ma'am. First of all, I would like to thank Sandeep Jasuja sir for giving the opportunity, and also I would like to thank Raj, those who have sponsored this session. So we'll be talking on the maximizing chances of cure in EBC setting. Next slide. So we always have the disclaimer. This is a sponsored session by Raj. So always discuss about the cure in EBC. Next slide. And which is many a times elusive. So what are the chances? Next slide. So as a clinician, we always find recurrences are quite common, especially in the high risk groups. So how do we deal these recurrences? That we'll be discussing. Slides are moving. Yes, my screen slides are not moving. Yeah. So in ABC, the goal of the treatment should always be cure, but as disease biology, especially HER2 positive, is always frustrating, and almost 3/4 of the patients relapse in such situation. So, and it ultimately impacts the patient's quality of life. So, our goal for HER2 positive disease should be have the effective treatment, reduce the relapses or recurrences, and improve the quality of life if at all there is recurrences. Next slide. So how do neoadjuvant therapy helps us? So neoadjuvant therapy helps us by facilitating surgery, like downstaging the tumor, which ultimately increases the BCS rates, reduce the complications of the surgery, reduces the need of revision of the residual tumor, and treatment choices for inflammatory and inoperable breast cancer. There is also a risk prediction for
in cases where the pathological CR achieved or not achieved. So it gives a fair idea about the relapse. And in recent year, PAT-CR has become one of the primary endpoint in many of the trials. And the last thing, which is response adjusted therapy. If there is no PAT-CR, how do we deal with such patients? We know this is a high-risk disease and this is going to relapse. So nowadays, with the current available data, we can modify the treatment based on the achievement of PAT-CR or non-PAT-CR. Next slide. So what are the outcomes of neoadjuvant therapy in terms of pathological CR? So how do we define once the neoadjuvant therapy is given? There are three possibilities. One, complete remission, no disease. And there is sometimes in situ residual disease. So there are few terminologies which needs to be defined and probably refined also. So TPCR is total pathological CR, which includes a complete CR in the breast as well as axilla. Then breast path-CR mainly focuses on path-CR in the breast, not in axilla. And then sometimes the whatever the disease remains, that is called as a residual invasive disease. So, and if there are incomplete responses, as we have already discussed, there are very high chances of the recurrences in non-path-CR patients. Next slide. So again, coming to the PAT-CR, how does this marker has come up as a new predictive marker that we'll see in subsequent slide. Next slide. So there is a meta-analysis of more than 27,000 patients where PAT-CR has been achieved or not achieved in its impact on recurrences, survival, and breast cancer subtypes by Laura M. and the colleagues. Next slide. So this was presented in December 2018 SADCS. So results where patients who had PAT-CR compared to those with the residual disease had significantly better EFS. And if we look at the hazard ratio of 0.31, again it's very impressive. So PAT-CR can be considered as one of the markers for long-term disease control. Next slide. So, what is the difference between PAT-CR and non-PAT-CR? We can find a corollary from the blood cancer, especially minimum MRD and non-MRD disease, minimal residual disease. So, it's like having the deeper responses, and if the deeper responses are there post-surgery, then obviously patients' EFS as well as OS will improve versus non-PAT-CR patients. Next slide. So to conclude on the PAT-CR patients who achieve PAT-CR have very good long-term outcomes in EFS as well as OS. Next slide. So we'll be discussing three trials in the neoadjuvant and adjuvant setting: Neosphere trial, Trifinus trial, and Affinity trial. So Neosphere was mainly phase 2 study Perjeta in the neoadjuvant setting, which had four arms, 100 patients in each arm, mainly dealt with Herceptin docetaxel or in combination with Perjeta Herceptin docetaxel. Third was only anti-HER2 agents, and fourth arm D was Perjeta plus docetaxel, followed by surgery and adjuvant treatment with Herceptin plus FEC, and A and B arm, C arm Herceptin docetaxel FEC, and Herceptin plus FEC. Primary endpoint were PAT-CR rate at the time of surgery. Next slide. So where did this stand? So we are talking about breast PAT-CR in this patient. So the arm PPH, PHP arm, where we had 45% patient had PAT-CR. Quite significant. If we look at the other graphs, like only N2 HER2 probably only 16%, but so chemotherapy backbone is required, but addition of the anti-HER2 will add the response rates and to the increment of almost 15%. If we look at the 5-year follow-up analysis of PFS, so PhD arm has nearly 5-year PFS of 86% versus only herceptin and trastuzumab is 81%. So there is 5% of delta. Next slide. So summarize, PATH CR rate of 45% versus 29% in PHT versus ST arm, and these findings are further support exploration of more comprehensive HER2 blockade in adjuvant setting, as well as establish the importance of chemotherapy as a backbone in the lieu of anti-HER2 agents. Next slide. So coming to the second study, Trifena, which is like phase 2 study, Perjeta and Herceptin in the neoadjuvant setting. So it had three arms, ABC, Perjeta, Herceptin, plus FEC plus docetaxel. FEC 1 to 3 cycles in combination, followed by Perjeta, Herceptin, docetaxel. And the arm C was TCHP arm, cycle 1 to 6. Surgery followed by Herceptin to complete 1 year. Next slide. Primary endpoint here was the safety and tolerability in the neoadjuvant setting for the cardiac safety. So next slide, we'll see the cardiac risk with various arms. Next slide. So this has been mainly divided into 3 parts: neoadjuvant treatment, incidence of cardiac toxicity in the neoadjuvant setting, then subsequently in the adjuvant setting, and in the long-term setting. So if we look at the LVSD all grades, or symptomatic LVSD grade 3, so those were the lowest in the TCHP arm, which is now very commonly used. In the adjuvant setting, again, it has the lowest grade 3, uh, lowest LVSD all grades in the TCHP arm. Though it had 1.5% patient in the adjuvant setting had uh, grade 3 events. And in the follow-up grade, LVSD all grades, again, we can say one of the lowest, 1.4. Again, the A also has 1.4%. So it will be a decline from 10% from baseline to less than 15%. Again, the lowest in the TCHP arm. So cardiac safety is very comparable across all the arms. Next slide. And if we compare the PATH arm, again, the TCH arm succeeds to the tune of 66% versus rest all others. So definitely TCHP has become a choice over all other regimens. Next slide. So current approach for the newly diagnosed HER2 positive EBC is like, if the disease is less than 2 centimeter node negative, go for upfront surgery. Node positive, then adjuvant pertuzumab plus arsulumab based regimen to complete 18 cycles. If it is node negative, then only you can go for the pertuzumab and arsulumab and paclitaxel. If it is more than 2 centimeter node positive, so we have to combine dual anti-HER2 along with the chemotherapy, 4 to 6 cycles, go for the surgery. If there is a PATH and upfront node positive, then we can continue with the pertuzumab trastuzumab based therapy. If it is node negative upfront, then we can go trastuzumab alone. And if there is a residual disease, change over to anti-HER2 agent to TDM1. So this is what the newer flowchart says about the neoadjuvant treatment in the EBC. Next slide. So what is the optimal therapy for patients who have PATH-CR? So affinity data demonstrates improvement in the long-term outcome IDFS with 1 year trastuzumab and pertuzumab combination. So we'll see in the subsequent slide. Next slide, please. So this is the neoadjuvant to adjuvant transition affinity 10 years of update. Adjuvant pertuzumab and trastuzumab combination in early EBC. It's like third interim overall several analysis with the efficacy update, median follow-up of almost 8.4 years. Next slide. So this trial mainly was conducted in nearly 5,000 patients, 2 arms, chemotherapy plus Herceptin, chemotherapy plus placebo Herceptin. Primary endpoint was IDFS. Anti-HER2 therapy was given total for 1 year. Next slide. So next slide. So we'll see the efficacy data. in 3 interim analysis. So first analysis at the end of 3 year, delta 0.9%, not much of difference, hazard ratio 0.81. At the end of 6 year, increase in the delta of 2.8%, hazard ratio of 0.76. At the end of 8 years, delta of 2.6%. Again, to curve at the 2.5% is more or less maintained beyond 8 years also, and hazard ratio of 0.77. So it is very promising data, especially in the intent to treat population. So if we look at the subset analysis in the node positive, that will be seen in the next slide, because that is these are the pre-planned subgroups, and that is a aggressive disease subset. So this is the IDFS in the no positive subset. So the delta, which was 2.5, around 2.5% for the intent to treat population, has reached to around 5% at the end of 8 years in the node positive subgroup. So node positive subgroup definitely has a advantage, long-term advantage for the IDFS in this setting. Next slide. So if we compare node positive subgroup versus node negative, again node negative has hardly any benefit. Even at the end of 1 year, unity is crossing the line. The ratio is 1.01. Vis-a-vis 0.72 in the node positive subgroup. So node positive subgroup, where it is an aggressive subgroup, where we can go for the adjuvant trastuzumab and pertuzumab combination. Next slide. Overall survival follow-up, please continue. Next slide. So OS, there is hardly any OS difference. So IDFS benefit definitely there. OS benefit is around 0.7% in intent to treat population. Next slide. In the node positive patients, the OS is not significant, statistically significant. But then if we go with the numerical values, the deaths in the node positive with subgroup as lesser with the dual anti-HER2 agents. Next slide. So to summarize affinity data, there is increase IDFS benefit is definitely there at the end of 8 years, even especially in the node positive subgroup. No IDFS benefit in the node negative subgroup, and OS data has not been established with combination, the non-significant OS. Next slide. Safety data. Next slide. We always worry about the cardiac toxicity of the trastuzumab or pertuzumab combinations. So let's go into the next slide. Next, let's see what was the cardiac toxicity. So again, the primary cardiac event or secondary cardiac event. If we look at the various analyses, the difference is 0.4 throughout all the analysis. So it's more or less not clinically significant. Secondary cardiac events, again, minus 0.01, minus 0.02, minus 0.02. So there are no new cardiac safety signals were seen in even the third interim analysis. Next slide. So cardiac toxicity by chemotherapy regimen. If we use anthracyclines along with the perjeta-herceptin, there is higher chances of cardiac toxicity versus in patients with the TCH group.
Dr. Manoj Mahanan, sir, I'm sorry to interrupt, but last 1 minute to conclude, please.
Yes, I'll finish. Just it's last 1 minute. Next slide. So this is the affinity data summary. There are no new cardiac safety signals. Next slide. So infusion, there are change of strategy in the IV infusion because IV infusions are long infusions. There is a large observation time. Challenges of improving the resource utilization, placement, and maintenance of indwelling venous catheter that has been addressed by the next slide. By the subcutaneous preparation of the Phesgo. This is the first subcutaneous preparation of 2 antibodies using human hyaluronidase. Next slide. It's a ready to use fixed dose formulation given, next slide, in 5 to 8 minutes. Loading dose is given in 8 minutes, and subsequently it is given in 5 minutes. So almost in terms of oncologists, most of the oncologists have shifted this to IV preparation to the subcutaneous preparation. Patients have also improved the oral responses for the subcutaneous preparation because lesser time in the hospital. Next slide. So there are multiple benefits: shorter administration time, less invasive administration, fixed formulation, so dose errors are reduced. Reduced time required for the drug preparation and administration, and no new safety signals has been observed with the phase. Next slide. Thank you. So I would like to thank everyone. Thank you. If there are any questions, I can take.
So thank you so much, sir. Maybe may I request Dr. Hemant sir to introduce the next speaker?
Yeah, good evening, everybody. Now, next speaker is Dr. Rajat Govind. He will talk on role of trastuzumab deruxtecan in HER2 expressing tumor. He is a consultant medical oncology, Army Hospital, Research and Referral, Delhi. Over to Dr. Rajat.
Okay, good evening, everyone. Am I audible?
Yeah,
Yes, sir, you are audible.
Okay, I'm sharing my screen. Shika, just see whether it is being shown.
Yes, sir, it's completely visible. You can
Okay.
start.
Okay. Good evening, everyone. Thank you very much, organizers, for allowing this opportunity to speak on HER2 expressing tumors and the role of the new kid on the block, that is trastuzumab deruxtecan. Not able to go ahead. Can you change my slides? Yeah, there you go.
So you can go ahead.
Suddenly, I'm not able. Yeah, okay. 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 So this is what we are going to discuss over the next, say, 10-15 minutes. One is, what is the role of this new drug called Enhertu in the management of HER2 positive in the metastatic breast cancer setting? The second one is this introduction to the new entity, which we call as HER2 low, and what are its clinical applications and implications and the present scenario. And finally, we try to summarize in 10 to 15 minutes. So this is what it is. The TDXD, what is it? It has got basically 7 key attributes, and that is what makes it a unique molecule. It is an antibody drug conjugate, as we know. It has got 3 components. One is, of course, the anti-HER2 component, which is trastuzumab. And here it is covalently linked to a topoisomerase 1 inhibitor payload, an exatecan, which is with the use of a cleavable linker. It is a tetrapeptide, very high drug to antibody ratio. That is where it differs from the other congeners such as TDM1. It has got a drug to antibody ratio of 8. It has got a stable linker payload. It has got a high potency. This payload that is used, the topoisomerase 1 inhibitor, it has got a very high potency. It is stable and it is tumor selective. Additionally, it also possesses this bystander anti-tumor effect, in which once it enters the cell, through the breaking of this cleavable linker, it enters the neighboring cells as well to exert its anti-tumor efficacy. So this is how it enters the cell, the TDXD, which binds to the HER2 receptor. If you look at the right side of the screen, and once it is internalized, the linker is cleaved, it releases the payload, that is the topoisomerase 1 inhibitor, and that enters the nucleus and finally achieves the cell kill. Thereafter, it does not stop there. It moves on by permeating the membrane, and it effectively results in something called as the bystander effects into the neighboring tumor cell. So this is what it did. It demonstrated in the early preclinical trials. It showed about 60.9% response to therapy in previously treated HER2 positive metastatic breast cancer. Right. So DB03, we all know this is the first phase 3, got it into the forum. It was used in patients who were unresectable, metastatic, and those who were previously treated with a trastuzumab taxane arm. The patients were also allowed to have clinically stable, treatable brain metastasis. So that was something of concern in the HER2 positive. You know that HER2 positive breast cancers metastasize quite commonly to the brain. The primary endpoint here was the PFS. The secondary endpoint was, of course, the overall survival. So TDXD versus TDM1 was the comparative arm here. So this was the updated analysis. What we have so far, the PFS, if you see, look at the curves, they're beautifully separate right from the beginning, achieving a very impressive hazard ratio of 0.33. And if you look at the median survival in months, it is more than 3 times, approximately around 4 times benefit compared to TDM1, which was the standard of care in previously treated HER2-positive metastatic breast cancer. So this is what it did. The adverse events was not something that we were not aware. ILD, as we know, is a very specific side effect, even though we may not see it quite often in routine clinical practice, but ILD is very important for us to be aware of what this entity is, and then, of course, the routine other side effects encountered with such a molecule. So if you look at the key subgroups of interest, this was the use in the elderly population as well as the patients with brain metastasis. It shows an impressive survival benefit across all the planned subgroups. If you look at the patients with more than 65 years or less than 65 years, in both the subsets, you see, it showed quite an impressive PFS and OS benefit. If you look at the drug-related ILD and pneumonitis, as I sense, this was one of the concerns. So the rates were higher in elderly. Of course, the ILD pneumonitis incidence was higher in the elderly. Most of the drug-related, however, were in this case of low grade. So that was quite encouraging for us to use it, especially in the younger age group patients. So if you look at this, was the any grade incidence of ILD or pneumonitis. So it was the higher grades, the more severe pneumonitis was not very commonly seen. Now, the CNS PFS was something that we were very interested in. And if you look at the pooled analysis so far, the treated and the untreated, both the subset, the left and the right side of the screen, if you see, the curves are beautifully separating right from the beginning. And if you look at the comparator arm, 8.7 months versus 12.3 months, very impressive hazard ratios of 0.5. And if you look at the untreated brain mets, the benefit is even larger with a hazard ratio of 0.1. So these kind of unprecedented risk reductions have not been seen with much molecules in any oncological clinical trials. So this is something which was encouraging. So we look at the waterfall plots in the use of HER2-positive metastatic breast cancer as far as the pooled brain metastatic analysis is concerned. We can see that the responses were definitely much more with the use of Enhertu. As well as the leptomeningeal disease, this was another concern because we didn't have any very effective agents against this entity called as leptomeningeal disease. And here as well, we had a 73% response rates with the use of Enhertu. So Enhertu was very important because identifying this HER2 subset was very important. So moving on to the next clinical entity that we know as HER2 low. And what is this HER2 low and what are the clinical implications? HER2 low breast cancer, to be simply put, is the HER2 low, which is defined on the basis of IHC, which was 1+ or 2+ if the FISH was negative. So this is what we routinely do. If the patient comes out to be 2+, we do the FISH and the FISH comes positive, she's labeled as HER2 positive. But what happens if the FISH is negative in a patient who has got 1+ or 2+? Here comes the entity called as HER2 low. So it was very interesting to see that the majority of our patients, whom by conventional methods we were labeling as HER2 negative, were HER2 low. Identifying subset of HER2 low was very, very important. And this is what is now the challenge as far as the use of this entity is concerned. So as of now, if you really look, there are definitions of HER2 low, but they are not very uniform across all treating institutions. So there is no formally established clear parameters in defining this entity. There is also lack of awareness of this entity. There is tumor quality issues. There is intratumoral heterogeneity, which may affect the interpretation of the result. There is subjective variation amongst the pathologists as high as 30% when it comes to accurate and consistent scoring. There is limited tissue quantity especially during the time of relapse or recurrences, and there are limitations in IHC as well to detect these low levels. So these are the challenges in identifying the subset of HER2 low. If you look at the HER2 low efficacy of the HER2 low subset and the efficacy of Enhertu in this HER2 low subset, there is no doubt that in HER2 low as well, there is benefit with the use of this drug. So the DB04 trial, which is the phase 3 study here it used Enhertu in patients with HER2 low subset of disease. Here again, the PFS and OS was compared with the use of the physician choice of chemotherapy. And here again, the baseline CNS metastasis was allowed, and patients were previously treated in this subset. Here again, if you see the efficacy, beautifully separating curves of both PFS in hormone receptor positive as well as the whole subset of patients. So this hormone receptive subset was commonly associated, was definitely seen with the use of Enhertu as the median quite with the hazard ratios of 0.5, 0.51, etc. So if you look at the updated analysis, again, this consistently showing a benefit with an updated hazard ratio of 0.37. So over a period of time, the curves definitely separating even wider, 30% with the use of this drug compared to physician's choice of chemotherapy. Overall survival, the story is no different. Here again, if you see, there is some kind of push for the physician to use it in the hormone receptor positive cohort. So that is something that is very interesting to see. And what would be the biological rationale? The hormone receptor positive, is it something to do with the molecular profiling of the tumor, or is it something that we see usually with the hormone receptor positive? So this is what would be interesting to explore later on as this study progresses. So this was DB04 trial. If you look at the PFS hazard in hormone receptor negative, even though the benefit is there with impressive hazard ratios, the overall survival months, which is quite unprecedented with the use of any molecule actually in this kind of trial. So this again is the updated adverse events. If you see the concern remains ILD. The concern remains ILD, and the challenge remains in identifying this ILD as early as possible. So there are guidelines which help the physician or the clinician. There are handouts which help us to identify early on with the use of pulmonary function tests, with the use of clinical judgment. So we are more picking up more patients of ILD as our experience with the use of the drug is increasing. Response rates again.
Dr. Rajat sir, sorry to interrupt. Last 1 minute for
Just concluding. So lastly, just wanted to highlight as far as the subset analysis of DB04 is concerned, consistent benefit with the use of this drug. So there is no doubt that this drug is beneficial. Okay, this one last entity which we wanted to find out was this HER2 expression is very dynamic. So one expression is not static, and it may change over a period of time as the disease progresses from early to late stages. So this is what I was talking about the concordance rates between the historical and the central HER2 testing. So this is something that is a challenge for us to identify. TDXG related ILDs, again, this is a beautiful handout that is easily accessible for anyone to really identify, monitor, confirm the disease, how to manage with the use of steroids and interruption of therapy. So things are getting quite uniform as far as the ILD management is concerned. So this is what we generally practice in the clinic when we suspect TDXG related ILD. So to summarize, what is the take-home point? The take-home point is HER2 is a dynamic marker. This dynamic marker will demonstrate both intra and intertumoral heterogeneity. It will change from early stage to late stage. The proportion of HER2, which is higher in the hormone receptor subset compared to TNBC, if you look 65% to about 37% in TNBC. Both PFS and OS benefit in patients with HER2 low subset who have been previously treated. The benefit is seen across all subgroups. And the DB04 trial, because of the DB04 trial, the TDXG is approved in more than 50 countries, including the European, the American, and the Australian continents, including, of course, India. So that is what the recommendation is. HER2 low subset, metastatic breast cancer, both NCC and ESMO guidelines have updated to the use of HER2. So I have ended. Thank you very much. If there are any questions, we'll be glad to take.
Thank you. Thank you, Dr. Rajat, for such a brilliant presentation. As always, now with the paucity of time, may I request Dr. Mukesh Sonalia, sir, if you can introduce our moderator for the next panel, Dr. Chetan Deshmukh, sir. Over to you, Dr. Mukesh Sonalia.
So good evening, everyone. Next topic is panel discussion. That is management of oligometastatic breast cancer. For this panel discussion, I will invite to moderator Dr. Chetan Deshmukh. He is consultant medical oncologist at Dinanath Mangeswar Hospital and Research Center at Pune. Over to you, Dr. Chetan Deshmukh.
So should we wait? Sure.
Yeah. Good evening, Dr. Chetan, sir. Can you hear us? How are you, sir?
Good evening. I'm good, Tarun. How are you?
Very well. So, sir, all the esteemed panelists are with you. You can introduce your panelists, and the stage is set for you for the panel discussion. Dr. Devesh Goel, sir, is not able to make it. Rest, everyone is there.
Okay. So, yeah. Is my slide, is my PPT visible?
Absolutely, sir. You're audible, visible, and your esteemed
Audible?
panelists
Yeah,
are with
okay.
you.
Okay,
Yeah,
fine.
sure.
Just let me make it full screen and then we'll begin. Yeah. So the topic of discussion today is oligometastatic breast cancer, which is rather a gray area. I'll begin with the definition. We'll discuss the benefits and pros and cons of surgery, radiation therapy, and then we'll discuss a case scenario. So the names of panelists for whom these questions are directed are absolutely random, and anyone can take it. So if Dr. Anshul is there, you can take the question. So how many? I'm sorry, Dr. Anshul, are you there?
So your panel has Dr. Naresh Somani, sir, is available.
Yes.
So
Dr.
we have
Somani, I can see Dr. Naresh is right here in front of me. So Dr. Naresh, how many OMBCs do you
Good
see?
evening, everyone. So maybe two patients in a month.
Or two patients. It usually comprises about 20% of all metastatic breast cancers. Do you feel that with the advent of PET-CT becoming more and more accessible, the number of OMBCs is going to go up?
Yes, it's going up, but as we all understand that the defined criteria or the well-defined definition of the OMBC is still lacking in our mind to label it that which patient is OMBC. And sometime when the OMBC as per criteria is with the visceral mets, sometimes we just try to ignore it.
Okay. We'll come to that. We'll come to the definition of it because there are variable definitions. One is up to 5 lesions, any organ, any organ which is potentially amenable to local treatment. So even if there is a lung lesion which is amenable to resection or ablation with radiation, then that also may be considered as an oligometastatic disease because the number 5 is very arbitrary. Most of the real world data has used a cutoff of 3. Most of the studies they've said less than 3 versus more than 3. So probably for breast cancer, the number may be 3. About my other fellow panelists, what are the definitions you usually follow? Anyone from the panel? I'm sorry, I don't have the list of panelists with me.
Majority of the times, the 4 to 5 lesions we consider as a oligometastatic. But in the case of breast cancer, the 3 or less than 3 are we considered as oligometastatic.
Yeah, so 3 is the usual number which all of us have been traditionally following, and that is what all of us are more comfortable. 5 sounds a little too much. Probably it may not be as easily amenable to treatment with a curative intent.
Dr. Chetan, I would like to make one comment here. Can I make?
Yeah,
This point number 3, potentially amenable to local treatment. I think it is more like potentially ability to achieve the no evidence of the disease is a better criteria. So low volume disease or preferably 3 centimeter or something like that.
Excuse me, please stop moving the slides. I don't know who's moving the slides. I'll do it from here.
Sorry, all yours, sir. All
Yeah,
yours.
I'll do it from here. Don't worry. Yeah.
Sir, you are only sharing the slides from your side.
Yeah.
I think there is
No,
network issue.
from my side, there is no, I'm not touching the screen at all. Yeah, please go ahead, sir. Dr. Somani, please go ahead.
So it is something like ability or amenable to achieve the no evidence of the disease after local treatment or SABR. So that is probably more catching or more treatable scenario rather than just amenable to the local treatment. That is in my mind. And it should be preferably the low volume disease or maybe the smaller lesion, like something like 3 centimeter or so.
Perfect. That makes more sense, that any number of lesion may be variable. There may be more than 3 lesions, but if they can be tackled with a lobectomy, or they can be tackled by local resection, then that also should qualify as OMBC. Is that what you mean?
Yeah.
Fine, fine.
So also, sir, the biology, particularly for breast cancer, is equally important. So for a triple negative patient, I'll be on day one, even it is oligometastatic presentation, it is difficult to define. So most of the time it is more to do with a strong hormone positive or HER2 positive disease. So even in particularly breast cancer, the biology should also
We are
be
coming to
taken
that.
into account.
We are coming to that, Dr. Deepak. We are coming to that. And secondly, we are going to discuss only breast, oligometastatic breast. We are not going to discuss lung and other ailments. So, is there a difference between genuinely oligometastatic disease, that somebody has only one liver lesion and breast, whereas somebody who has an induced oligometastatic disease? As I said, oligometastatic is a gray area. There may be people on both sides. That exact definition is not known. So somebody may have previous metastatic disease, complete response on a PET scan, and now comes back with a solitary lesion either in the lung or in the liver. Will you call that oligometastatic disease? So maybe one of my panelists, is Dr. Taran here, Dr. Rakesh, or Dr. Sachin Jain?
Yes, sir, it depends. Even it is in the liver, even it is in the lung. The metastatic lesion, if they are 3 or less than 3, then we can consider it as a oligometastatic. But they should not be multiple, even in the liver or even in the lung. The number should be 3 or less than 3.
The definition, we are all clear that the number, the volume has to be low. But my point is, suppose a person has a de novo oligometastatic disease versus somebody who has presented with metastatic disease, responded, and then come back. Do you feel that there is a difference in their survival? Should we be treating the second metastatic disease also as aggressively as we have treated the first one?
I think the metachronous disease is less survival as compared to the synchronous metastatic disease, which is presented day one, because the patient is chemotherapy de novo. So there are both the chances to ablate the disease.
Yeah. So, oligometastatic disease is actually a big Pandora's box. We are looking at most of these cases will go through some kind of multidisciplinary team tumor board discussions. Of course, the standard frontline therapy will be a systemic therapy, but at some point of time, depending on the volume of disease, there will be a role for ablation or maybe even surgery for the primary tumor. Then whether molecularly they are different, can we detect oligometastatic disease earlier? Is there any need to rebiopsy the tumor, or if you are looking at a heterogeneity between the primary and the metastatic site? All these factors are going to come into play when we are dealing with an oligometastatic disease. Now, this was an interesting study that patients who had metastatic disease, they were de novo metastatic disease, they underwent combination chemotherapy and they had a complete remission. What happened to these people? Quite a few of them had oligometastatic disease. Those patients who had a complete response, a fair amount of them had oligometastatic disease. So about 1,500 odd patients, of which 263 patients had a complete remission. And of these 263 people, there were, of course, some relapses in the first 5 years, but there were some people who died without their breast cancer coming back. So it was they died with no evidence of disease. And in these 263 patients, there were 49 patients who were in complete response even after 5 years. That's an impressive statistics. And 26 of them continued to remain in complete response. 4 of them died without any breast cancer disease. So there seems to be some role of this aggressive treatment for especially a low volume disease. And this is of course an old paper, but this is what probably gave the idea that there is something called an oligometastatic disease. Most of our real world data, all of us agree that it is 3 or less than 3 mets. And these are the patients who have higher chance of achieving a completely
a complete response. We clearly believe that it is both qualitatively and quantitatively different. Probably OMBC is less virulent than polymetastatic breast cancer. So, any of my panelists, do you feel that it is a distant biology which is behaving this way, or should we treat them as just a polymetastatic disease caught at an early stage? Dr. Naresh, what do you feel?
So, as you commented in the beginning, that the disease which is happening oligometastatic after previous treatment versus de novo. The de novo disease, the primary and the sites of the mets, biologically, they are more or less similar. This has been proven by the various studies. While a patient which is relapsing under the chemo selectivity or the chemo pressure is more chemo resistant and more heterogeneous disease. So that is more aggressive probably. In my opinion, it is the biology of the disease, like the type of the like ERPR or HER or TNBC versus these points are more important rather than just calling them as the oligometastatic versus polymetastatic disease. Oligometastatic, even if it is the TNBC, as Dr. Deepak was just commenting, that probably is not for the treatment purpose, for the outcome purpose, like the oligometastatic, where you try to treat them as the local treatment. While a patient ERPR positive patient, HER negative, coming after 2 years or de novo limited disease is entirely different. Rather, I would like to call this sort of the disease as the stage 3D, rather than calling them as the stage 4 disease.
Yeah. That's an interesting hypothesis that you call it stage 3D and not as
and I'm very optimistic that this term will come sometime, at least in our lifetime, that the 3D will be there, a new stage.
3D will be there. Yeah, possibly. No, the idea why I said was that this was an interesting study from PLOS-1, that microRNA profiling showed that there is a possibility that oligometastatic disease is different to begin with. So there are predictors of progression based on microRNA assay, and some of the oligometastatic may progress to polymetastatic, but there will be some who will remain oligometastatic, who will do well with oligometastatic disease itself, and probably will be long-term survivors and complete responders. So patients who fail to develop polymetastasis, they have some unique features of microRNA, which includes the microRNA 200 family. They have, this study had studied some xenograft models in which these patients had, they could discriminate between the two. So microRNA 200C enhancement in an oligometastatic cell line resulted in polymetastatic progression. So something there is probably some different genetics which is causing some of the tumors to behave a little less virulent and coming at a lower volume compared to a florid polymetastatic disease. So this is, of course, at a very, very early level, cell line and xenograft level. We'll still probably see it more and more as we probably sample more and more of our oligometastatic disease. So these are some oligometastatic entities. One is a synchronous or de novo oligometastatic disease, where patients present with an oligometastatic disease at their first presentation. Sometimes it is an oligorecurrent. So there is a management of a non-metastatic tumor. Patient has been treated with a curative intent and now has come back with very limited disease. So this is, or there may be an intermediate stage where you feel that there is a localized tumor, and probably it's not, the progression is not happening floridly, but then at a later date, if you allow it to fester, it goes on to develop polymetastatic disease. And it is important now that this was a thought earlier, it was always thought that if you have a metastatic disease, handling the primary is out, don't touch the primary. And the hypothesis was that probably the primary is suppressing the metastatic disease. Now we know that you have metastatic disease which may be genetically different from the original tumor itself. So is there a role of doing treatment of the primary when there is florid metastatic disease? So this was the whole idea behind surgery in stage 4 disease. So whether we should control the seeding from primary tumor site, or it should we reduce the formation of tumor stem cells within the primary tumor stroma. This was the thought. And as we all know, you cannot keep a surgeon away from operating a breast cancer, metastatic or non-metastatic. That is why there were quite a few studies. One was the famous Tata Memorial Hospital study by Dr. Badwe et al. Then there was a Turkish study. There was an ABCSG study. And as latest as 2020, there was an ECOG 2108 study. So this was Dr. Badwe's study where loco-regional treatment versus no treatment of a primary tumor in metastatic breast cancer study was done. These patients were all de novo stage 4 breast cancer, and they did not have only oligometastatic disease. They had a fair amount of metastatic disease. All of these patients were given 6 to 8 cycles of anthracycline or plain anthracycline-based therapy. Most of the parameters were well balanced, but some of these patients had a lot of disease. Bone-only metastasis was seen in only about 30% of the population, whereas almost 40, 43, 44% patient had visceral metastasis, and another 25 odd percent patients had both bone and visceral. Less than 3 metastasis was seen only in 1/4 of patients. So a fair amount of metastatic disease was there. HER2 positive disease as usual is about 25-30% only. But remember, very few patients received HER2 directed therapy. Most of these patients received anthracycline based therapy, FAC or FEC, and a small number received anthracycline, and an even smaller number received paclitaxel. And of course, hormone therapy was given. The result was there was hardly any difference in the overall survival. With loco-regional treatment, 19.2 months at the end of a median follow-up of 23 months. And with no loco-regional therapy, the median OS was 20.5 months. The curves are almost overlapping each other. Only a small subgroup of patients where the odds ratio is favoring doing loco-regional therapy is patients who had a tumor met less than number of mets were less than 3, and only this group had some benefit. Apart from that, there was no benefit. But there were some comments about it. Maybe some of my panelists can comment, Dr. Sachin or Dr. Pinaki, Dr. Rakesh, if he has joined. What do you feel about this study?
This was a well done study, sir. And I think what was actually shown here was the patients with bone mets did worse actually when you gave them both the things. So I think biology is the king. In breast cancer, we can all agree that biology is the king. So even an oligometastatic disease, if the biology is good, we expect that patient to survive a long time. And I think that is the way to treat. I would distinguish my patients between early and metastatic. That is how. And these patients I would treat as a metastatic setting. If those patients do well on systemic therapy, then probably local ablative therapies would be my second option and not the first option per se. That is my thinking.
Right. So there were criticisms of this study as well, that the systemic therapy was largely suboptimal. Today, most of our patients go on anthracyclines sequentially or in combination. HER2 directed therapy was not given in a large population because the study happened in early, probably enrollment happened when the HER2 directed therapy was beyond reach of most of the population. There was no question of giving CDK4/6 because again the patient population was, the study period was much before the advent of CDK4/6 inhibitors. But nevertheless, surgery shortened distant progression-free survival, which is again not a very nice thing to happen. Again, this study was, this is a more recent study, published in 2020, did in 2020. They published it in ASCO 2020, and the article came in 2022. Again, de novo metastatic disease, where patients were given optimal systemic therapy, and if the patients did not have progression of distant disease following 4 to 8 months of therapy, then only these patients were offered whether to go in for continued systemic therapy or offer local therapy. And the local therapy was usually complete tumor resection with complete surgical margins, and follow it up with post-operative radiation therapy as and when required. Most of these patients had single organ distant mets. Bone only mets were 37% and visceral mets were only 24%. So more biologically favorable disease, as Dr. Pinaki rightly mentioned. Probably these people had selected their patients very wisely. 70% of the population was postmenopausal, and most of these patients were either ERPR positive, HER2 negative, or HER2 positive disease. TNBC was less than 10%. But in spite of selecting a very favorable population, a very choice population, there was no improvement in overall survival, no improvement in PFS, no improvement in OS in any of the group. In fact, the OS was worse with for triple negative group. So, Dr. Pinaki, I'm going to come back to you. You said that biology is the king. Now, here they've chosen favorable biology. So, why do you think this has happened?
So it
The
basically means
survival
that
curves are almost overlapping.
So basically, what it means to say is that these patients were anyway going to do well, and therefore the local therapy that you did was useless. It did not add anything. So maybe we don't do the local treatment in these patients anyway, because they were biologically good patients.
Yeah, no, definitely, except for triple negative, all these patients, triple negatives they did very, very worse. So there was no question of disease. In fact, with early local therapy, the progression was worse compared to only systemic therapy. But these people haven't given up. People kept on trying. There is another of this study, the positive study. Again, surgical resection of primary tumor versus only primary systemic therapy. Overall survival did not do well, except for this Turkish study. I don't know. I tried to get a full text of this study. I couldn't get it. But this is the only study which has shown that there is some benefit. Again, de novo metastatic breast cancer patients given systemic therapy alone or systemic therapy plus locoregional therapy. And with locoregional therapy at a median follow-up of 46 months, there were almost 20% patients who were alive. And there was the hazard of death was 29% lower in the locoregional therapy. That this is the only study. And if you see the forest plot, almost all the hazard ratios are favoring locoregional therapy, whether it's ER positive, whether it's HER2 positive, HER2 negative, triple negative, age irrespective, bone met, other mets, everything. So this is the only study which is something very, very strange. So maybe my panelists can comment why this study is such an outlier.
Dr. Chetan, there are essentially two components when we discuss about the oligometastatic disease. One is you are talking and highlighting the local therapy.
Yes.
The other is the taking care of the oligometastatic sites. So,
you mean the systemic sites?
TMH study, Turkish study, and other studies, they were basically essentially talking only about the local treatment in metastatic disease without realizing how to find out the difference of the local treatment in the oligometastatic setup versus the disseminated metastatic setting. And obviously, the treatment will keep changing. Today, if you talk about the ER/PR positive patient in metastatic setup, we have the 3 lines of the hormone therapy, then we have the chemotherapy, then we have the PARP inhibitor, then we have even the TDXD in the HER1 plus 2 plus ultra low, this and that.
Yes.
So obviously the part played by the local treatment or the part played for the oligometastatic site will vanish or will be masked by the sequential treatment versus trying to show the difference where the limited systemic treatments are available. Correct. Let's say typically like the TNBC situation. So in my opinion, these are the reasons that probably we will never be able to show any benefit of the local treatment in the given scenario in the metastatic setup. Because we will keep treating these patients with the various modalities of the treatment, 3 lines, 4 lines, and so on. So even if the minimal difference is there or was there in the previous studies, which are 10 years or 20 years old, and the landscape of the metastatic systemic treatment has changed drastically, probably it will never be beneficial. So we need to talk only about the irradiation or the treatment of the this oligometastatic site, and probably the best is the dealing when only the bone mets are there. That part probably we are missing in our discussion, that probably the best subset is when only the bone mets and the oligometastatic sites are there.
So this is what their study also had, that their
Dr. Chetan, sir, great discussion, but you have last 5 minutes with your panelists.
I know. I have my watch right here. Yeah. So locoregional therapy, they selected their patients smartly, that they had lower TNBC, higher ER positive patients and solitary bone mets only. So probably that is why their study showed benefit. Apart from that, all these studies put together, most of them have not shown any benefit of locoregional therapy. So probably at the end of this discussion, I can only summarize it in such a way that ER/PR positive tumors, bone only or limited metastatic disease, young patient population, good performance status, patients who have responded favorably to systemic therapy. Probably these are our patients who should be considered as candidate for treatment like an oligometastatic status and not like a polymetastatic disease. Dr. Naresh mentioned about ablative radiation therapy. Of course, radiation therapy Now we have fantastic radiation machines where we need not worry about collateral damage. We have SBRT, CyberKnife, Proton, everything. So for patients who have had uh, oligometastatic disease, this was, mind you, this was all cancers and not only breast cancer, but nevertheless, they have had this study of randomization to either palliative RT only to symptomatic sites and the systemic therapy. Patients up to 5 metastatic lesions were taken, or patients also received stereotactic ablative radiation therapy. Again, the number of breast cancer patients was very, very small, only 18 patients. But nevertheless, the overall survival was better in the patients who underwent stereotactic ablative radiation therapy. So probably there is a role for SABR. Again, very small study, less than 100 patients, only 18 of them were breast cancer, but 5-year OS looks impressive, 42.3 versus 17.7. And grade 2, grade 4 adverse events were also less. So this was probably one of the first randomized studies which showed an OS benefit. So about my panelist, most of you probably are working in a multidisciplinary setup where your radiation oncology colleagues are also there. So what is your discussion with your radiation oncology colleagues when you have such an oligometastatic situation? How often do you push them for stereotactic radiation or ablative radiation?
Good evening, Dr. Chetan.
Good evening, Dr. Rajesh.
I do agree that this is a subset which has to be taken care and it is tough to resist not offering a curative intent. If at all it is feasible, we should go ahead with curative intent with using all the modalities, whatever is feasible, or with CDK4/6 inhibitor coming in and with PARP inhibitor coming in breast cancer, HER2 directed therapies which are increasing in numbers. So we should offer it upfront.
Yeah. So, there was another study also. This was loco-regional symptom-directed therapy versus ablation of all metastatic. This was a breast cancer study. They had less than 4 meds, but they planned to ablate all meds, not only the oligometastatic, but all meds. Unfortunately, this study did not show any benefit. This study was a negative study. The PFS benefit was not seen. So the authors have actually concluded that they are not going to proceed with the phase 3 component. So this is the reason why I showed this study is this is a word of caution for us that we'll probably need to draw a line and decide which are the patients where we are going to offer aggressive ablative therapy. Having said that, aggressive ablative therapy with radiation is of course much more safer compared to surgery. Imagine doing a lobectomy or a segmentectomy for a liver compared to only radiation, which is much more safer. Now we have immunotherapy in even the advanced triple negative subset. Now, these are patients who show very good responses. We have seen that in the neoadjuvant setting as well, that they have fantastic complete response rates. So probably these patients, though triple negative has traditionally been taken a backseat, so far probably with the use of immunotherapy, we'll see more and more responses. And probably more and more patients will come to fore for oligometastatic treatment in triple negative as well. I agree with Dr. Naresh. He very rightly pointed out that metastatic disease spectrum, as it is changing with systemic therapy, we are probably going to keep changing our paradigms, and probably the role of aggressive local therapy will be reduced and only will be limited to ablative therapies with minimal toxicity and minimal morbidity to the patient.
Can I make a comment?
One thing, sorry?
Can I make a comment?
Please, please.
So when you were talking in the randomized trials, they all failed. What positive data we have is basically from the retrospective or data collection or small phase 2 kind of the studies. But we often talk about the overall survival and the PFS. If we talk about in different perspective for the oligometastatic setup treatment, that is the local control and time to the next treatment. So the radiation oncologists or we people need to look the oligometastatic disease and its treatment in a different perspective. Overall survival and PFS, as we discussed, is not there, and probably it will never be there, in my opinion, because of the newer systemic treatment. But if we look from the different perspective or an angle, that is the local control versus time to the next treatment, which is not exactly equivalent to the PFS,
Yes.
then maybe that the SABR or the local control of the limited metastatic disease will be justifiable in select group of the patients.
Select group of patients. Fine. So ctDNA assays are coming up now. We are getting more and more requests for ctDNAs. Probably this will have some role in guiding therapy. We'll probably be able to pick up oligometastatic disease earlier. And Tarun, I don't think we have time for the case, but just a quick comment from my some of my panelists. Anyone can take it. So if we have a high volume TNBC, say somebody with more than 4 nodes, do we treat this as OMBC and keep on giving systemic therapy? We normally give these patients olaparib for a year, or we put them on capecitabine for 6 months to a year. Should we continue it as till progression like the way we do it for metastatic disease? Any one of my panelists. We are running out of time. It's already 20:55.
I will go more with the drug holiday concept like what we have in the colorectal. So even if you say that the biology is equivalent to OMBC, it's better to give the drug holiday.
Okay, okay. For what about my other panelists?
I do agree. I do agree with Somani, sir. I think too much is not that good.
Too much may not be a good idea. Okay, okay. So, Tarun, we are we running out of time, or do we have time for the case?
No, so I'm so sorry. So we're actually running out of time. Maybe the esteemed panelist, if Dr. Deepak Shukla wants to add something, Dr. Sachin has said, Dr. Pinaki Mahato is there. If one minute, I mean, one points from everyone, and then
one point from each panelist, that would be great. Thank you.
So, sir, as we discussed, so oligometastatic should be decided not by only number. Biology should be the key. The initial part is systemic treatment, and based on the response, MDD discussions should be taken to give local treatment or not. And it is a case-by-case discussion.
Right.
Agree with
Can we
Deepak,
hear
sir.
from Dr. Pinaki?
Yeah, I agree with sir, and I think as Naresh sir also said, if the patient is on treatment, one can also go for a drug holiday, especially if you're thinking it's a good biology disease, one can also go for a drug holiday in case-to-case basis.
So, Chetan sir, please conclude, and then we ask
Thank
the
you,
speaker.
thank you. That was very interesting. And just to so OMBC, we are going to probably see more and more OMBCs because we are doing more and more PET scans and CT scans. It is biologically different. It's probably prognostic as well as predictive. Maybe the microRNAs are going to tell us whom to treat us differently. We need to treat them with a curative intent depending on the biology. We'll probably start calling them as stage 3D in the near future. And the key is going to be smart selection, making sure that all the team members in the multidisciplinary approach are involved and they know and they are helping us. HR positive, HER2 positive disease, of course, biologically they'll do better because we have excellent systemic therapy for them. Bone only metastasis, yes. Lymph node only metastasis, probably. Lung only metastasis, probably will need to be treated, but we'll need to approach a lot of caution for patients who have liver and brain metastasis. TNBC is still, it's a maybe situation depending on the biology. We still haven't understood the complete biology of TNBC, and that is why these patients are probably not doing very well. I think that's my last slide, and thank you all the panelists for a very interactive and a fruitful discussion. And over to you, Tarun. Thank you.
So thank you so much. Thank you so much, Dr. Chetan sir, and all the esteemed panelists for a wonderful discussion. May I request Dr. Sumita ma'am to invite the next speaker? Ma'am, are you there?
Yeah, I'm there. The next topic is emerging first-line therapy for HR positive, HER2 negative breast cancer to overcome endocrine resistance. For that, I invite Dr. Kaushal Patel, who is senior medical oncologist at Elite Oncocare Hospital, Surat. Over to Dr. Kaushal Patel.
Thank you. Good evening to all. Hope you can see my slides. Nothing new in 2025 in management of the advanced breast malignancy with hormone positive tumors. We all know we are very well experienced with the CDK4/6 inhibitors since long times, and it is very good drugs in our clinical practice to handle in our practice. These are my disclaimers, and yes. So while choosing the first line treatments in such type of the patients, we are having many factors to be considered. If we see patient point of view, then impact over quality of life as well as the survival. Disease point of view, then how the disease is aggressive, like visceral metastasis, how the clinically disease is in visceral crisis. The definition of visceral crisis is also very different in different literature. Even it's a different for different clinician also. And which treatment patient has received previously in clinical practice. If we simplified the things according to the guidelines in advanced breast malignancy, then if we see the first line treatment option, if the patient is having no any organ failure imminent, then we can go with the endocrine therapy plus CDK4/6 inhibitor as a first line category 1 recommendations. And on progression of the disease, depends upon the features, we can have multiple lines of the treatments. If the patient is having imminent organ failures, then we can go with the chemotherapy. If patient is having BRCA positive, then we can go with the PARP inhibitors. If the patient is having PIK3CA mutations, then we can go with the fulvestrant plus alpelisib. We have options of the everolimus plus exemestane, everolimus plus fulvestrant, and fulvestrant alone if it is not used previously. This definition, this graph has been little bit changed in 2025 after the ESMO Breast 2025 last week updates. And they have added one more PIK3CA inhibitors. They have also added the drugs which has ESR1 receptor mutated populations. They have also added a PIK3CA mutated first line along with the CDK4/6 inhibitor plus endocrine therapy in a first line setting. So there are certain changes happens during this ESMO 2025 breast updates. If we see the three key trials, Mona Lisa 2, Paloma 2, and Monarch 3, then if we see the PFS point of view, then every single drug is its age over the only endocrine therapy in postmenopausal patients. And any of the drugs, if combines with the AI, is useful in a first-line metastatic population. But if we consider the overall survival rate, then only ribociclib in Mona Lisa 2 has shown a significant advantage in overall survival rate in postmenopausal populations, while other two drugs, they failed to show any statistical significant OS advantage in Paloma 2 and Monarch 3 studies. If we see the side effect profiles of the each CDK4/6 inhibitors, then there is a little difference has been documented except pancytopenia. Diarrhea is more common into the abemaciclib group of the drugs. Certain cardiac prolongation has been more pronounced into the patient who has been treated with the ribociclib, and same is also correct with the asymptomatic elevations of the liver enzymes. While rest of the things like leukopenia, anemia, and thrombocytopenia, they are a little bit more pronounced into the patient who has been treated with the palbociclib. But this is very good drug to handle in our clinical practice. Higher grade side effects and side effects which lead to the discontinuation of the treatments or modification of the treatments are very less common in our practice with this any of these drugs which we are using right now. If you see the current standard of the first line treatments in view of the CDK4/6 inhibitors, then according to the quality of life, almost all drugs, they are better. Ribo and Palbo, they are more tolerable drugs compared to the abemaciclib because of diarrhea, which is there, which is having troublesome side effects sometimes in initial phase of the time intervals. But the palbociclib as well as ribociclib, they are very good drugs to handle in our practice. If we see the different trials and different trials result in postmenopausal as well as in premenopausal, then almost all drug has shown a better advantage. Ribociclib has certain advantage in form of the overall survival rate, while other two drugs, they are having advantage in PFS as well as OS. So any of the drugs can be used in clinical practice, depends upon patient scenario. But NCCN has considered the overall survival benefit is in a first line setting advantage, and they recommend ribociclib plus AI as a category 1, as well other two CDK4/6 inhibitors with combination of the endocrine therapy as a category 2A recommendations. Ribo is little bit different compared to the other available option of the treatments. It has 8-fold difference in activity of the CDK4 compared to the palbociclib. and ribociclib having a higher level of the exposure in plasma compared to the other available option of the 4/6 other CDK4/6 inhibitor. Ribociclib is highly selective CD4/6, which lead to the less off-target dose-limiting toxicity. So that may be the reason for the OS benefit across all studies. Quality of life has been maintained across all studies, and efficacy across the difficult to treat populations like visceral metastasis, CNS metastatic, and endocrine resistant populations. If we see according to the patient's characteristic wise, then if we see the patient who are having only bone metastasis, then we can have median overall survival rate as approximately 6 years with the ribociclib, and overall response rate with AI is approximately 56.4 months. So definitely the ribociclib when added to the endocrine therapy in only bone metastasis, there is a more than 6 years OS has been documented. If we consider the age more than 75 or elderly populations, then definitely the higher overall survival rate has been observed with all age group, which has been treated with the ribociclib plus endocrine therapy, which include the elderly populations. And if we divide subgroup, then the patient who are having more than 75 years of age, they are having more pronounced benefit compared to the patient who are having less than 75 years of the age. And more than 3 years overall survival has been documented with the ribociclib in more than 75 years of the age group. If we see the liver metastasis, then ribociclib has 29% relative risk reduction into the death who are having liver metastasis compared to the patient who has been treated with the endocrine therapy. And the same thing has been also reflected with other visceral metastasis. The percentage of the relative risk reduction is 22% with ribociclib plus endocrine therapy, and much better with combination compared to the single agent. There are no any significant number of the patient has been enrolled into the key studies of the CDK4/6 inhibitor who are having brain metastasis. There is hardly single digit number of the patient has been enrolled in the study because that is an exclusion criteria. But we have subgroup analysis with complement one real world experience, which includes 51 patients who are having CNS metastasis. And these are having a different group of the populations and different real world experience. If we see the patient who are having CNS metastasis, they are having long time to progressions with ribociclib compared to the patient who has been treated with the endocrine therapy. And a patient with CNS metastasis has a trend towards the long time to the progression of the treatments versus overall difficult to treat populations. And if we dissect this things further, then OS in all patients who are having more metastasis, like more than 3 metastatic sites, there is also getting advantage with the ribociclib plus endocrine therapy, and there is an absolute 27% relative risk reductions with the ribociclib plus endocrine therapy. And we have one study recently published in last year. December 2024. That is a right choice study. In this particular subset, the patient who has been having a significant disease burden, clinically aggressive disease, and to a certain extent, the patient who are having visceral crisis, who has been given ribociclib plus endocrine therapy versus combination of chemotherapy of physician choice. And it has shown significant difference has been documented with the progression-free survival rate in favor of ribociclib plus endocrine therapy compared to the chemotherapy. So it is almost double advantage has been documented. So we can say that the patient who are having clinically aggressive disease, fastly growing disease, in this particular subset of the populations, even ribociclib plus endocrine therapy is doing better compared to the chemotherapy arm. Overall response rate, overall response rate and time to treatments relapse is also more into the patient who has been treated with the ribociclib plus endocrine therapy compared to the chemotherapy combination. If we see ESMO 2023,
Sir, can we request you to conclude now?
Yeah, give me 2 minutes. If we see the post-hoc analysis of the Asian and non-Asian populations, then definitely the Asian patients, they are getting advantage more with the ribociclib plus endocrine therapy compared to the non-Asian population therapy. And it has compared with the chemotherapy combination therapy. ABC 6 and 7 concessions guideline also says that the ribociclib plus endocrine therapy having better result compared to the other available options of the treatments in form of the chemotherapy combination. In patients who are having endocrine resistant, OS benefit in patients with the endocrine resistance therapy was not in same range across the all CDK4/6 inhibitor in all phase 3 studies, but it is more pronouncedly documented with the ribociclib, and these are the things which has been different OS. But the OS differences due to different population has been enrolled in this particular study in this endocrine resistant population. So I conclude my talk that ribociclib has make a life easier for patients with hormone positive and HER2 negative breast malignancy. It has definite edge over other two in form of the overall survival rate compared to the other available option of the treatments. Easy in titrating the dose as per clinical status of your patient because it has 200 milligram tablets dosage, and easy in ensuring the good efficacy while maintaining the quality of life index of our patients. So I thanks for organizing, for giving me the opportunity to speak on this topic, and I thanks my audience for the patient hearing. Thank you.
Thank you. Thank you so much, sir. Thank you so much for such great presentation. We might have some couple of questions, but we first like to thank our esteemed chairpersons. Thank you, Dr. Sumita Jain, ma'am. Thank you, Dr. Hemant Adi, sir. And thank you, Dr. Mukesh Nania, for your presence. Now we move to the last session, and this is a panel discussion, which is the patient management consideration in HR positive, HER2 negative early breast cancer. To do the honors, may I request Dr. Mohit Agarwal, sir, Senior Director and Unit Head Medical Oncologist at Delhi. Good evening, Dr. Mohit Agarwal, sir. Would you like to share your screen and invite your panelists, please?
Good evening, everyone. So, can I have the slides from your side? Because I was informed that the slides will be straight from your side.
Yes,
Okay.
sir. Just a second. Yeah.
Yeah. So by the time we adjust the slides, it's a pleasure to invite the esteemed panelists for this panel. We have Dr. Sandeep Kukkar, sir, Director Medical Oncologist at Sohana Medical Hospital, Mohali, and then we have Dr. Ankur Punia, Consultant Medical Oncologist at Mahatma Gandhi Medical College Hospital, Jaipur. And of course, we have esteemed panelist, Dr. Manoj Mahajan, sir, Director Oncology Services, Senior Consultant Medical Oncologist at Pacific Medical College and Hospital, Udaipur. So once again, good evening, and thank you so much, Dr. Mohit, sir. Over to you for your discussion, please. Just say next slide, sir.
Sure. So, good evening, everyone, and a heartfelt thanks to the organizers for giving me this opportunity.
Sir, your voice is not clear. If you can be a little louder, sir, please.
Okay, sure. Just a second. Am I clear now?
Yeah, better, sir. Please go ahead, sir.
Yeah, okay. So a warm good evening to everyone, and a heartfelt thanks to the organizers and Novartis for giving me this opportunity. As a standard disclaimer, these slides have been provided by Novartis, and the topic of discussion for my end as a moderator is early breast cancer, specifically in a hormone receptor positive HER2 negative subset. And we are changing gears from what Dr. Kaushal had said from an ABC setting to EBC setting. So at least in an ABC setting, we knew that we are going to use the CDK4/6, but here the situation is a bit different, which will be discussed with our panelists. So can I have the next slide, please? Okay, so we have already invited our panelists, and I hope all of them are there.
Yes. Dr. Manoj is.
Okay. Thank you. So next slide, please. Okay, so we start on with the case straight away because let's not waste time. We are precious time, and let's start discussing on the case. So what we have here is a 45-year-old premenopausal woman with a stage 2B cancer and 2 clinically positive lymph nodes, so fitting into a category of N1. She's grade 2. The tumor size is 4 centimeters, fitting into T2 category, and the Ki67 of 35%. And if you see the Oncotype DX excellence score of 27. Now, so next slide, please. Okay, so I can see Dr. Ankur Punia on my screen. So, Dr. Ankur, so seeing these criteria, do you consider this patient to be at high risk of recurrence?
So yeah, patient has few characteristics which would
place her at a high risk. First of all, the patient is premenopausal, a little bit young patients, and one status is there, though it's a little bit in between, but still two nodes are positive. Grade 2 tumor, not a well differentiated tumor. Recurrence score is on the intermediate sky 27, and Ki67 is on the higher side 35%. So we look, if you look at by the Natalie criteria, it fits into that high risk population. It's not entirely a low risk population, not entirely a very high risk person, but still this patient is at high risk because of multiple factors.
Okay. So, Dr. Sandeep, do you buy these Natalie criteria? So, and as per you, do the Natalie criteria suffice to go ahead with the, something additional to the whatever standard what we were giving?
So I think for node positive patients, I agree that's a total. N0 might be debatable, but if it is node positive, I consider Natalie criteria as a point of selection of treatment.
So if a node positive, I'll be coming on to a node positive case later on. So I'll be discussing that point over here. So for you, a node positive, you will actually consider your Natalie, but a node negative, you might not.
So I'm convinced with N0 disease also, but still, given the proportion of patients in Natalie, that was approximately 15% of the patients were N0. That is a point of debate that one might not consider node negative patients for an adjuvant treatment for certain subset of patients.
Okay, fine. We first discussed this case.
Right.
This is a node positive case, and by your point, you say that node positive.
I go ahead with adjuvant treatment.
Okay, so Dr. Manoj Mahajan, if you are there, how do you assess risk for patients who are node positive? Though there are some characteristics mentioned over here in the criteria, what are your parameters to decide that this patient would be fitting into a high risk category?
So we should look for the criteria beyond node positivity, especially if the number of lymph nodes are less than 4. So like grade of the tumor, recurrence score is already 27. That has already been done. Then once the grade is done, even in certain situation, we can also look into the Ki67. And as Dr. Ankur has rightly pointed out, 45 years lady premenopausal, so that can be considered in certain situation. But primarily, I would once less than 4 nodes, I would look for the grade, then Ki67, and then recurrence score or any other genomic profile markers. If I've looked.
So supposedly this patient recurrence score had not been done. We had not, many of our cases are the ones where the oncotype BX testing has not actually been done. And the Ki67 score is around 15%. Then in this setup of a T2 N1 category, do you consider this to be a high grade in a grade 2 situation? And do you consider some additional treatment?
Yes, as per the Natalie criteria, I think, and there is adequate evidence for considering this group as also high risk. So I think, though classically we'll not say it's very high risk, I think we need to define high risk and very high risk. Probably very high risk as per the ABEMA trial, and high risk as per the Natalie trial.
Okay, fine. If you define and differentiate as per high risk or very high risk, how does it change the therapeutics?
Therapeutic, we have evidence for both the options. So definition will just categorize, and based on that, we have two molecules which have adequate evidence for giving the adjuvant treatment. The only thing is whichever molecule you are comfortable. If you look at the data or maturity of the data, I think ABEMA has a larger data, more high risk patients defined. But again, more high risk patients is a subjective term. So if we go by the trials, I have two options. Whichever option is feasible, financially feasible, as per my experience is feasible, I would prefer one of them.
Okay. So Dr. Sandeep, Dr.
No,
Manoj
I think continuing the debate, the initial trial that recruited patients, one of the criteria was Ki67 more than 20%. So although they outsightedly, I think in the subsequent publications, they outrightly said that Ki67 might not be considered for selection of patients. But I think given this patient profile, I agree that this patient is, even if it is the recurrence score or oncotype DX information is missing, then again, she would classify for as a high risk patient.
So can I have my next slide? And then I'll go into further discussion. Can I have my next slide? So, we have been talking about the risk factors and considerations. This patient is a grade 2. Okay, and this patient has a node 1, where you have a nodal positivity. So as per Natalie, do you require any additional criteria? So why are we talking, if you are convinced with the Natalie, then why are we actually really bothered about the oncotype risk score or the Ki-67 index? So how are they confounding the facts?
So I guess it's not about the confounding. It's about the what are the risk factors we'll look into. I'm not saying if this patient has, if talking about this patient, 2 lymph nodes possible, then that makes the Natalie criteria is fulfilled. But if what other criteria do we look for? That is what we are enumerating.
So if the other, my question to you is straight, that if the other criteria are supposedly not met, either due to unavailability or because they are actually low. So Ki-67 is low, but you have a single node positivity. In that case scenario, are you willing to buy the Natalie and go ahead with your CDK4/6?
Yes.
Okay. Dr. Sandeep?
So for this particular patient, I agree that...
No, I'm not talking about this particular patient. Let's not complicate the matters. I'm giving you a special situation where we are not discussing about the Ki-67. We are not talking about the oncotype DX. It is the scenario where we have a one single node positivity.
So only node positivity would not be the criteria, I would say. Only node positivity.
So you are not in concurrence with the entire Natalie score. That means.
See, I think I look at the patient profile. Every patient would not fit. Say if it is a 75-year-old patient who comes with a node N1 positive disease, do I consider for an adjuvant letrozole and ribociclib? I think I might not. So
if you have a PS1 75-year-old patient who is a PS0, why not consider?
So
you consider age to be a criteria.
So, Dr. Mohit, I think this patient selection has to be defined as per. We see patients who are at 85 years or 90 years, they are fit enough, and we see that 40 years of the age patients are not fit enough. So age is not the only criteria. If you look at that, only N1, if you say the node positive, comparing Natalie versus Monarchy, yes, I agree that node is one of the criteria, but it is not the only criteria.
No, Sandeep, Dr. Sandeep, you are complicating the matters right now.
I guess you are
when you are talking about the single patient profile, then you can have many things. You might have a comorbidities where you might not be able to give the drug. The
so
patient might be having.
That is what I'm saying. No,
we are talking about a patient which is coming into a normal OPD with a simple scenario of a N1 disease, not taking into consideration the comorbidities. In those comorbidities, maybe you even can't give an AI.
So for that, if it is a normal patient, node positivity classifies as a high risk criteria.
Okay, so that is, you want to take ribociclib. Yes,
yes.
Okay, Dr. Ankur, what I wanted to understand from you is that when you have a very high risk and a high risk classification, as we all perceive because of the data of Monarchy, where you had some patients who had a very high risk criteria pattern, and the Natalie came later on. So is it our bias that maybe the high-risk patients, the abemaciclib is going to perform better as compared to the, ribociclib? Or we feel that both the molecules are same?
What I feel is, yes, we need a longer follow-up, but whatever data we have, we can look at it that the highest risk group as per Monarchy, the delta is more or less the same. As we go in the lower risk subgroup like N1 or N0, the delta is going to be small. So what I feel in the long term result might be not that much difference in that highest risk subgroup. But taking that point you said earlier regarding risk group stratification for N1 disease, no other risk group. So what I feel is a single risk factor should not define to give such kind of a treatment, what I feel. Because N1 earlier, it was a slightly dicey thing. We used to think N1 is not high risk, but a large EBCTCG analysis told that even N1 patient, benefit from all these kind of therapies. So number to treat is obviously going to be high. If we treat a lot number of patients, then we are going to see a benefit, but that benefit might be small. benefit most patients who are going to benefit are who I'm going to have a multiple risk factors. And one, as I said, along with all guys, other risk factors like premenopausal grade, even a point which I forgot is the ERPR positivity percentage also, which I feel makes a difference. So such kind of additional risk factors, I will think will make me more confident to use a CDK4/6 inhibitor for this N1 subgroup.
So I buy all of your points, and even Dr. Sandeep's point. It's very hard to convince yourself and a patient who is coming with a N0 or an N1 disease, hormone positive, to say you would actually have to go for an additional CDK4/6 inhibitor. But whatever the trial has come out with the facts and the data is as per right now, we have to respect that fact. So we are discussing those facts. So so if you have a comparatively low ERPR positivity, so I would say, as you made out a point, Dr. Ankur Punia, that say supposedly ER is 4/8 and PR is 4/8, and you have a N1 disease, maybe a high Ki-67 index as well, then you don't want to go ahead with the CDK4/6?
Such patient will be, I think, is at a high risk. For this patient, I will certainly consider to add a CDK4/6. Maybe because for this patient, just a hormone therapy might not be adequate for such a patient with a low ERPR, because we have evidence that these patients don't do that much well with just hormone therapy, and in the long term they have poorer outcomes. So maybe additional therapy is a very good point for such kind of a patients, as was seen with soft and text study, in which adding OFS was particularly beneficial in that subgroup also, for that patients who are ERPR low.
So, Dr. Sandeep, do you concur? A high ERPR and a low ERPR, where do you want to add a CDK4/6?
So I think for me, ERPR would not be the only criteria. If it is high risk, it is high risk. ERPR positive, whether it is high or low, I will certainly add CDK4/6.
Because Dr. Ankur, I feel that then you can actually argue the different fact that maybe your hormone pathway is not active. What will you gain by adding a CDK4/6 if
So
you buy
maybe
that
that's why
concept?
we are adding a drug which is acting in a slightly different pathway. That's why it might be helping more,
but that
not
is going
just
to help
directly
only
involved in the hormone pathway.
But that is active only in a hormone positive pathway. You cannot give it in a ERPR negative setting. It has
seen
not shown
benefit.
any effect.
If you look at the molecular data of the Mona Lisa, subgroup complete analysis, they showed benefit even in HER2, molecularly HER2 positive patients benefited,
Yeah,
not the
fine.
PNBC. So
We
maybe
have
some
a
patients are benefiting. We don't know why. So that's why I'm saying, because it has some other, it's just
the
not a
HER2
CDK4/6 inhibitor. It affects on some other pathways as well. So that's why I
Dr. Ankur,
consider that maybe.
HER2 positive septate benefited because it was ERPR positive. It did not benefited because it was HER2 positive.
That's why I'm saying it was molecularly HER2 positive. That's why I'm saying this is a sub point where I consider abemaciclib slightly more better option, because of some that off side effects, off kinase effects. It might be acting on other pathways, which might be the cause of this low activity of ER or PR. That's why I consider this an important marker to decide whether to give CDK4/6.
Very interesting point. Dr. Manoj, your take on this point by Dr. Ankur? You feel that lower ERPR, you want to go ahead with CDK4/6, considering that it might stop you some other pathway?
Sir, by the definition, ERPR low and low ERPR and 8+8 has not been defined by both the trials. First thing. Second thing, if you see, we have clinical experience that low ERPR positive don't respond that great to a hormone therapy. And as like CDK4/6 ultimately acts on the same path, but it increases the sensitivity of the hormone pathway rather than it has a different kind of action. It just enhances the CDK hormone sensitivity. And if there is ERPR low positivity, uh, especially even in metastatic setting, what clinically I have experienced, these are not the good subsets where the even adding CDK4/6 adds much benefit. I cannot quantify it, but that is what the clinical experience is. But still, considering we don't have any option, and if the patient is high risk, I would like to add it.
So I think that the panel is divided on the same fact, but my understanding of the fact is that any hormone positivity we have to consider it as a hormone positive, and we should add a CDK4/6 irrespective of the fact that whether it is 4/8 or 6/8 or 8/8. Anyways, I think we will have some further studies for the same. May I have my next slide? Next slide. Can I have my next slide? Okay. Okay, now, Dr. Ankur, 4 positive lymph nodes. So
No doubt about
low
it.
ERPR, low ERPR. No. High ERPR, okay?
High ERPR, no doubt about it. I will give along a CDK4/6 inhibitor.
Okay. And any choice of CDK4/6 in over here? I know it's
Yeah,
a difficult question. Even we are not clear, but your choice.
It's just a preference. I prefer to give abemaciclib.
Okay. And Dr. Sandeep, your choice?
So I have more experience in using abemaciclib rather than ribociclib.
Because it is not yet approved, so we haven't had our hands on it. Okay, I understand that fact. Okay, Dr. Manoj?
Yes, in adjunct setting abema.
Okay, so you feel, so what we feel is that when we are actually fulfilling those high risk monarchy criteria, you want to go with abema. This is because maybe we already have an experience regarding this thing. Okay, I buy your point. Next, please, next slide. Okay, now
Mohit sir, you have last 5 minutes to conclude with all your esteemed panelists.
Sure. Okay, so we'll go fast. Okay, so what percentage of our patients actually fulfill the monarchy and Natalie criteria? Sandeep, your take, Dr. Sandeep.
So I think it will be hardly around 20%.
No, which monarchy or Natalie?
So I would say monarchy.
And Natalie?
It will be almost the same, 20-30%.
But Dr. Sandeep, Natalie would also involve N0 and N1, no? So those criteria which were not there in the monarchy. So you will have
that is what I'm saying. Slightly higher than percentage, it will be difficult to define, but slightly higher than monarchy.
Okay. Next slide, because I want to get the next case into perspective. So this was the real world evidence which showed that monarchy actually qualifies to about 15% of the patients, but the number exactly doubles when you go into Natalie, because the reason being that you have a lot of patients who are actually N0 and N1. Next slide. Okay, so this was the real world evidence again of the fact that how many percentage of patients are actually more in terms of the criteria of Natalie when you give go ahead Natalie, and how many patients actually would fall into the category of giving this ribociclib. Next slide. Okay, next slide. Okay, so this was the thing. The IDFS in node positive EBC, though we do not have a specific data for an N1 disease, but you see a delta of 2.7 at the end of 3 years. And at the end of 5 years, the delta is 5%. I understand this would involve N1 to N3. We want to specifically have a data for N1, which will be coming in some future. Next slide. Next slide. Next slide. So anything about the safety profile, what we want to get about? Any concerns when you are giving ribociclib or abemaciclib? Abemaciclib, we all know is diarrhea. What is our concerns when we give Natalie? Dr. Sandeep?
So I think I have not used particularly in the trial setting of Natalie, but considering the metastatic setting, I think both the drugs are pretty safe in terms of, if you see abemaciclib, the diarrhea part is also overrated. So not majority of the patients, they do land up with grade 3, grade 4 diarrhea. But again, both the drugs are equally potent, and I think without much of a hassle in dealing with the side effect profile.
Okay, so in the interest of the time, I'm just pointing out the fact that about 20% of the patients in the Natalie actually discontinued the drug due to adverse events. And the most common reason was liver dysfunction, but that is one of a teen of about 7% only. So actually this trial was conducted during COVID time, so we never know the reason behind the discontinuation. Next slide. Okay, and another important point is that when you go for a dose reduction in Natalie, you actually do not get any decreased response. The response rate remains the same. The IDFS remains the same. Next slide. Next slide. Next slide. Okay, now this is the important case which I wanted to brought about. 58-year-old lady post-menopausal, grade 3, T2N0, KI67 19, less than 20. Dr. Ankur.
So what I feel is grade 3 patients do tends to do worse. So grade 3 is, I think, a big prognostic marker. There is a not that small delta between, if you see the data of all the trials, grade 1, 2, there is some difference. But as soon as we compare grade 2 versus grade 3, there is a marked difference between the relapse risk. So grade 3, I personally consider is a very high risk marker for such patient, even though it's T2, Ki67 is borderline, I will consider this patient at a high risk of relapse.
So Dr. Sandeep, N0.
Concur with Dr. Punia.
Okay. Okay, next slide. Okay, so now Dr. Manoj, N0, what are your factors in consideration when you decide about giving the CDK4/6 or not? Is it exactly the copy of Natalie, or you make some twitches and cuts?
I would like to follow her like exactly copy grade 3, but definitely clinical considerations are there.
Oh,
So
that is okay. We understand
yeah.
that. But otherwise, any of these Natalie criteria suffice for go ahead with the ribociclib?
Yes, sir, can consider.
Okay, Dr. Ankur.
Yes, sir.
Exactly, you want to follow the Natalie here?
For a case like this, I will guess.
Okay. Next
So
slide.
we don't have a cutoff for Ki67 also, but considering the fact that in the trial it included 20%, so 19% or 20%, how do you, even if you remove grade 3, how do you classify that 19% is not high risk and 20% is high risk? So I agree
that will always be there.
Yes.
Because Dr. Sudeep, when you talk about PDL1, you have to take a cutoff.
Yeah.
So if the speed limit is 60, 61 is you get a challan, 59 it's fine. So that is you have to take a cutoff. Okay. Next slide. Next slide. So these were all the factors which you all were actually telling to bring about that how do you assess the risk factors and how would you actually fit it into a patient and what all criteria would be there. So because we are short of time, I would like to finally end from you. Are we all convinced with the data of Natalie? And there are two questions for each of my panelists. Are we convinced with the data of Natalie and are we willing to give ribociclib in N0? Secondly, when we are fulfilling the criteria of monarchy, then our choice is monarchy or Natalie. So we start with Dr. Sandeep.
So question number 1, yes, 20% of the patients even in N0 would be those who will relapse in future. So for N0 also, I would definitely consider adjuvant CDK4/6 inhibitor. As of now, we have the data for Natalie. I agree with the data, and we can choose ribociclib as an adjuvant CDK4/6 partner. So there are many things to look at. One more thing to point out is now I think as the science has evolved, maybe future generation in the coming few decades, we will see that circulating tumor DNA might also complicate the picture in selection of the patients, those who are at high risk. We will go beyond the histopathological features and Ki67 and node positivity with the selection of patient based on circulating tumor cells. So that's all from my side.
Okay, and what about the monarchy and the Natalie when both the criteria are met? You choose monarchy or the Natalie?
Difficult choice to make.
No, but you have to make it. You have a patient tomorrow in your OPD. What do you do?
So I think as of now, I'll choose abemaciclib because I have used in majority of the patients I have tried abemaciclib. So that's my personal choice. Nothing against ribociclib.
Okay, Dr. Ankur.
Dr.
So
Mohit, sir, sorry to interrupt again, but we need to close.
But just last 1 minute. Last 1 minute. Yeah.
So only my opinion is that yes, the ctDNA has already pointed out molecular things are coming up in a big way, but a thing which we might not be able to do for majority of our patients for a long period of time. So what I feel is a risk scoring system based on all these risk factors will make a much more bigger impact that what should be done, which I told Novartis and each and every person that will, are able to identify better which person to target. So yes, for N0, even that point out N0, some patients will relapse. We have to pick them up and give them some additional treatment. And regarding Monarch and Natalie, I am more comfortable using abemaciclib.
Because of the okay, Dr. Manoj.
For N0 disease, again, as per the defining criteria as for high risk, if it fulfills, then I'll go for it. Even the upcoming markers, if they are like come up in the addition of other markers, then we should accept it as per the data. And second, I would prefer a ribo against the other panelists because I'm more comfortable with the overall side effect profile is very less as compared to slightly compared to Abima. That is what my personal experience is. But I would prefer a ribo over a Abima. But again, both the options can be utilized, and I have used both the options in this setting.
Okay. Okay, so that brings us to the end of this discussion. And I think our final take is that we actually are all convinced with the Natalie data as of now. And we would like to use this molecule in the criteria fulfilled. However, when it comes to both the criteria, when the patient is meeting both the criteria as per our experience, which would be growing in times to come and the data, we'll be choosing our molecule. But at the moment, we are divided amongst ourselves as to which is the best molecule in that case. If I have rightly put it such, so I would like to end this panel discussion, and a very big thank to the panelists for such a lively discussion. We tried to spice it up so that it doesn't get boring.
Okay. Thank you. Thank you, Dr. Mohit and the esteemed
Thank you.
panelists for
Thank you.
such a lovely presentation. Now, we give the final floor to Dr. Sandeep Jasuja sir for his final comment, and then we will close for the day. Over to you, Dr. Jasuja sir.
Again, friends, very good evening. And I think at this late evening, we might be either hungry or feeling some sleepy. So we conclude the first day of session of our Precision Oncology Unplugged. I extend my heartfelt gratitude to all of my distinguished speaker, panelists, and attendees who contributed to today's remarkable sessions. We witnessed an incredible exchange of knowledge on lung and breast cancer advancement, including the integration of NGS, ctDNA, targeted therapy, immunotherapeutic approaches. The insightful panel discussion, but we have just listened, also enriched our understanding of the real-world challenges and evolving treatment paradigms. Your enthusiasm, engagement, and sharp clinical insight have set the tone for what we promise to be an equally stimulating day two. So I encourage all of you to carry today's discussion forward and return tomorrow sharp at 6 p.m. with a fresh energy as we are delved into GI, GU, and hematological malignancy tomorrow evening, which includes update from the ASCO ASH and also recent innovation in the transplant and molecular oncology and hematology. So let's continue to collaborate, challenges the norms, and re-image the future of oncology together. Thank you for being part of this vibrant academic journey, and I wish you all a pleasant evening and good night for today. Thank you very much, everyone.
Thank you, Dr. Jasuja sir, for just a wonderful closing, and thank you to all our esteemed panelists, chairperson for joining, and everyone who joined. See you till then. Good night, and we'll see you again tomorrow at 6 p.m. So do log in. Thank you, sir. Thank you so much, and good night, sir.